For your information, I've started a recording now, Holly.
Justin Baker, just want to check your audio.
Any luck? No audio?
Yes. And just checking if Joshua Gordon's audio is working. So good morning, everyone, and welcome to the NIMH sponsored workshop, virtual workshop on transforming the practice of mental health care. And I want to give a few minutes while our attendees and panelists sign on. My name is Holly Lisenby, and really am delighted that all of you are able to join today. I see now that we do have Joshua Gordon signed on. Josh, just wanted to test your audio.
Hi, good morning, everyone.
Good morning. So I've just opened the workshop and want to welcome everyone to this workshop. And to get us started, I'd like to introduce the director of the National Institute of Mental Health, Dr. Joshua Gordon, who is going to give us some introductory remarks. And then I'll come back with some format and goals for the workshop. So welcome, Dr. Gordon.
Good morning, everyone. Welcome. Thank you for joining us today, both the panelists and attendees. Really excited about this workshop. It certainly will hopefully be a break from the humdrum every day. I know that most, if not all of you, are like I am, working from home, and that your lives have been quite disrupted by what's going on. So I want to acknowledge that first, and to thank you for taking time out of your schedules and for dealing with childcare and whatever else you have to deal with. And we understand if there's a bark in the background, if there's a kid that comes, and needs something. So don't worry about that. But we're really pleased that you could all join us today. One question you might have is, why are we doing this? Why is the NIMH having a workshop on transforming the practice of mental health care? This workshop is meant to be really, truly forward-thinking. We're trying to imagine what the practice of psychiatry could be like if we took advantage of the tools that are coming online now. We know we can do some pretty amazing things in terms of the understanding and treatment of mental illnesses if we can harness these tools. What kinds of tools am I talking about? I'm talking about the ability to get broad data sets from a number of different features about our patients, be features of the brain activity, features of their past experiences, features of their longitudinal course. If we can harness all these data, and I suppose that my geneticist colleagues would kill me if I didn't say features of their genetics as well. If we can put all this data together, we can learn a lot more about our patients, learn about a lot more about the illnesses that they are struggling with, and potentially move from a practice of psychiatry, which is based on self-reported symptoms and based upon best guesses on the part of the clinician and the patient as to which treatment options are going to work best for them, are going to be most tolerable for them, et cetera, into a data-driven practice where we think about patients, yes, from the personal narrative perspective, that will always be part of psychiatry, but also from the perspective of what's going to work best for them and what's going to give them the greatest chance of feeling better and the least chance of side effects. My model in thinking this is the modern day oncologist who gets as much data about the cancer that her patient is suffering from, and gives that patient a series of treatment options, each of which is accompanied by a probability of success and also a probability of side effects. And then with that information in hand, the patient and the doctor can work together to decide which treatment is most appropriate for that particular patient in that particular situation. This kind of model of the practice of psychiatry will require, number one, a lot more research. We need to be able to obviously answer lots of questions about our patients, about both in aggregate and in individual, in order to be able to imagine this kind of psychiatry. It will also require an infrastructure. It will require large data sets that are integrated and that have both depth in terms of depth of data about individual patients and breadth in terms of large numbers of patients. It will require knowing which kind of data that goes into these data sets. And finally, it will require a decision engine. It will require an infrastructure that will allow psychiatrists and patients to put data in, and an algorithmic infrastructure that will process that data and give probabilities and likelihoods back to the psychiatrist in order to aid the patient. So that's the big picture we're talking about. We're imagining a different kind of mental health care, one that is patient-centered but data-driven. And we're trying to think, what do we at NIMH need to do? How can we take what is really a wonderful revolution of new technologies and really bright people, many of whom are assembled here today, who are working with these technologies to learn about our patients, but what can we add to this mix to bring this future potential into reality? And finally, I'll just say what I said at the beginning, which is this is a very forward-thinking workshop. We're not imagining that we can accomplish this vision in the next 6 months, in the next 5 years, maybe not even in the next 10 or 15 years. We're really thinking forward, but we're recognizing we need to lay the groundwork now to be able to achieve that vision in the future. So again, I really want to thank you. I'm very much looking forward to the day, and I'm going to turn it back over to Holly.
Thank you, Dr. Gordon. And I'd like to thank you, Dr. Gordon, and Dr. Shelley Agnelli, the Deputy Director of NIMH. And also, I'd like to thank our moderators who have graciously volunteered to help organize the content and the discussions we'll be having today. The moderators for our first session on the future vision of where we might be able to bring mental health care through the advantages of data and technology, specifically Drs. Andrew Crystal and Justin Baker. I'd like to thank our moderators for our second session, which will take us through learnings from existing networks and efforts underway. That's Drs. Guillermo Sapiro and Helen Egger. Our third session moderators will help us understand the challenges in getting from where we are today to where we want to go in the future. That session will be led by Dr. Jen Goldsack and Jeff Gerard. And our fourth session on ethics and special populations, co-moderated by Drs. Dilip Jesti and Jeremy Vinstra Vanderweel. And I'd also like to thank our program committee, starting with Monica Carter, who is known to most of you because she really made this happen and really is doing a lion's share of the work here. I'd also like to thank the Acting Deputy Director of the Division of Translational Research, Dr. Mee Hillefors, and the members of the Planning Committee here at NIMH, Drs. Jenny Pachinko, Susan Azrin, David Lightman, and Adam Thomas. I'd also like to thank our speakers. We know that devoting most of the day is a tremendous ask of your time. We've invited you because of your complementary expertise that will help us think through where research can make the most impact in transforming mental health care. And as Dr. Gordon acknowledged, we understand that the world has changed since when we first organized this workshop. And we understand as a consequence, some of you will have to be leaving early. or not participating in certain parts of this. And we want this to be flexible. Please, we understand that you need to come and go based on your time schedules and challenges. So the purpose of our meeting, as you heard Dr. Gordon explain, is to assemble a group of experts to help us understand how multiple streams of data, including electronic health records, biomarkers, genomics, digital tracking, physiology, and imaging, can be used to inform treatment selection in mental health care in the future. A key deliverable from this could be technologies such as clinical decision support, software tools, or other aids to aid treatment selection. We've designed this program today to hear from a large number of experts from diverse disciplines in a short period of time to help us shape our thinking on these topics at a very high level. The format of our workshop, it is open to the public and this will be recorded and archived in a publicly accessible format. For those of you who need it, we do have live captioning, which is available in the multimedia viewer and in the lower part of your screen. You do need to click on that to activate the live captioning. A few housekeeping notes. As you join, please mute your microphones. We understand we do have a brief break in the middle of the program, but we don't have a formal lunch break or meal breaks. So please do take breaks when you need to. We're also having attendees from various time zones. And so that resulted in some aspects of our time frame here. Please note that there's a chat function and a Q&A function on WebEx, which you can use to direct questions to the panelists during the discussion sessions. So those are actually all of my introductory remarks. And so now I'd like to turn to introducing our first session. So our first session is focused on the desired future state, what problems we hope that new technologies and data-based approaches can solve for us to improve mental health care from the perspective of patients, providers, health systems, and payers. And so I'd like to introduce the co-moderators for session number one. Dr. Andrew Crystal is professor of psychiatry and vice chair for research at the University of California, San Francisco. He's an internationally renowned expert on sleep and mood disorders, and he's joined by Dr. Justin Baker, who is scientific director of the McLean Institute for Technology and Psychiatry, and the director of the Laboratory for Functional Neuroimaging and Bioinformatics at McLean Hospital. Now I'd like to turn it over to Dr. Crystal to kick off our first session.
Thank you very much, Holly. Just want to make sure can be heard. Thank you. As Holly mentioned, the first session is about the big picture, what it is that we hope will be achieved in the future, and what this will do for the treatment of people with mental health problems. And we're going to be looking at this from the perspective of some key stakeholders in this, that is the providers, health systems, payers, and we have brought together a group of distinguished scientists to help us with this process. And each one of these individuals will be presenting one slide, and we'll have 2 minutes to discuss their perspective. And myself and Justin Baker will be moderating and keeping everybody on track. And after the presentations from our experts, who are the panelists for session one, we'll have a time for question and answer. Questions will be entered using the chat function of the web interface. Now I want to turn it over to Justin Baker, who will start us introducing the panelists for session one.
All right, well, thank you, Andy, and thanks everyone, Holly and Josh, for hosting this exciting event, which I'm very pleased to be part of this morning. I think we all recognize that in this time, especially, we're faced with new access issues for mental health, and the visionaries you're going to hear from today are really charting the course for the that desired future state of psychiatric practice. And so we're going to hear from 8 separate speakers here this morning. Very briefly, each speaker is going to present a single slide representing their vision for the future of psychiatric practice. And we're going to start here with Terry Gleason, who is the Director of Clinical Science Research and Development Service in the Office of Research and Development at the VA Central Office in Washington, D.C. Dr. Gleason has a distinguished research career of nearly 20 years of VA service and has held many leadership positions across the government. And today she's going to be speaking to us about her vision and the VA's vision for where psychiatric practice is headed. So Terry, please.
Thank you, and good morning, everyone. I'm just delighted to be here. Yes, it's an extremely busy time for us in VA, but I think it sets us to be just right in terms of thinking about visioning and actually a way forward, as Dr. Gordon described, way into the future and how we get there. So the place that I sit in VA is the research office, which is embedded in the national healthcare system. And what that means, of course, is that we're in a unique position to generate questions that need to be answered for our veteran population, drive the research for them, and bring them back the results right into the healthcare system. So the depth and breadth of data and the richness of data that can be generated if we are greatly organized and forward thinking means that the potential is just possibly boundless. So there's so many resources that can be brought to bear in terms of thinking or conceptualizing a learning healthcare system. So right now, today, we're in the midst of this crisis. I saw numbers yesterday that reflected 1,600 cases in VA of confirmed novel coronavirus cases. And unfortunately, we're at a level of 53 deaths as of yesterday. These are, our veterans who have served, and I think it's a really important point about how sobering the moment is. On the other hand, I do want to bring to the group that what that means is we can actually capitalize now on the learning lessons that we're going through as a system and for research that just makes this conversation all so timely. So what I'm hoping for, it's not reflected on my slides, but what I'm hoping for is in this vision and moving forward, we can take all the learning opportunities of things that seemed like challenges, whether it was related to regulation or policy and so forth, the delays in research, the using of data and so forth, we can capitalize on that and turn it into a situation where we can make progress faster because now we know it can actually happen in real time. So I did just want to make that global note. Our AI team are busy working 24/7 data scientists across VA to capitalize on all the data that we need to draw conclusions for the coronavirus. And in the same regard, we can eventually put that experience to work for mental health and other scenarios as well. So just briefly, I'll walk through, the vision for mental health research in VA, as I said, a diverse system, and I'd like to take into account at the patient level, we need the best evidence base, and that's obviously produced by rigorous science and using everything that we can. I think it was already listed, but all of the richness of data that can be brought to bear for the patient and directing that and what that means, from the time they walk into the door till the treatment plan is developed, and then the response is actually known and recorded in a real way and accessible to research. For the providers, we need evidence-based treatments, and we need the level of knowledge that they can use that takes in consideration patient and system level factors to derive the best treatment plan for our patients. I want to bring in comparative effectiveness research questions because I think that should be a part of the vision, and how that could work in the future is a tangible, I think, approach that we can actually make progress on quicker if we all get organized around that. And then, of course, at the systems level, talking about what a learning healthcare system really needs. And as we capture data at the entree point for patients and move that through research level analysis and bring it back to healthcare, implementation is really the complete picture, I think. The challenges, very quickly, all of the above I mentioned, including data integration that starts from the beginning with a common set of assessment tools, perhaps not so much leaning on self-report, but considering what we can bring in terms of organization and standardization of data across the system to begin with. So I'd like to stop there, just keeping note of my time, and I'm happy to stay at least through this panel with you today. Thank you again.
Thank you so much, Terry. Yeah, speaking of time, I'm gonna actually restrict. Let's try to restrict direct remarks just a couple of minutes for each of the initial speakers. And what we'd like to do is broaden it up to a discussion among the speakers for the remainder of the hour. So if that's okay, I'll go ahead next to David Ledbetter.
Yes, can you hear me?
Yes.
Okay, thank you. I'm glad Josh got in a quick mention of genetics. I'll try to summarize where we are in genetics with a future vision that will have complete genomics information on every patient in a clinical setting and every patient participant in a research setting. Our goal at Geisinger is to have complete genomic sequence information on every baby born as part of routine newborn screening to inform healthcare throughout the lifespan and to allow us to prevent disease rather than always reacting to disease. So at a high level, for many common adult diseases, there's evidence from twin and family studies of very high heritability or significant genetic contribution. These range for things like cardiovascular disease risk, obesity, diabetes, many other common diseases, from about 20 to 80%, or heritability estimates of 20 to 80%, and on average 50%. So the pie diagram there, and you can adjust the relative sizes of each category to your preference, but I'll use 50% genetic risk factors. What I like about genetics is the human genome is big, but it's finite. We now have a very good map, and we have tools to measure accurately the DNA sequence of the entire genome of all individual patients, all individual research subjects. And I think that allows us to sort of remove one degree of freedom and complex multifactorial traits on a clinical and a research basis. To the right, I've shown the two best characterized psychiatric disorders in terms of common genetic variants, which comprises the heritability index coming from GWAS studies, but now being translated into polygenic risk algorithms to predict risk of disease based on hundreds and thousands of different small effect contributions. In autism, heritability is among the highest of any disease known at 0.9 or 90%. For schizophrenia, also quite high at 0.8. And people are working on developing polygenic risk scores in order to predict risk of disease for these disorders. For rare variants, so rare Mendelian genetic disorders, copy number variants or single nucleotide variants, in pediatric autism, depending on the cohort, up to 25% have a single large effect size rare variant that's the main contributor to autism. In schizophrenia, a much lower yield of about 5%, with 22q11 deletion syndrome being the most common and well-known, well-described risk for schizophrenia. Below that, I've shown that to get this genome-wide SNP data is now about $50. And the algorithms for developing polygenic risk analysis are getting better and better. People in the field are not using them and planning to use them as standalone, but incorporating them into other disease prediction risk, the most advanced in cardiovascular risk prediction and some cancer risk prediction. Whereas DNA sequencing to identify rare variants is still in the $500 to $1,000 range, even at scale for exome or genome sequencing. The bottom conclusion is stratifying cohorts by genetics decreases heterogeneity, I think will increase power in identifying important environmental lifestyle factors contributing to risk and help us to more efficiently identify effective interventions and treatments individualized to patients' genetic background or the presence of a rare genetic disease. So the goal actually is for clinicians and researchers that you won't have to think about genetics. We will have genetics data on everybody, every individual patient, every research subject, and that will be built into predictive algorithms, other models characterizing cohorts of patients for clinical use and for research. So I'll stop there.
Excellent. Thank you so much, David. That's exciting. So next we're going to hear from Amit Etkin and Corey Keller. Amit is the founder and CEO of Alto Neuroscience. He's a professor currently on leave to Alto in the Department of Psychiatry and Behavioral Science at Stanford University. Corey is an assistant professor in psychiatry and behavioral sciences at Stanford, and also the chief medical officer with Alto. So, Amit.
Great. Thank you for organizing this event. Let me just say very briefly, one view of the future in psychiatry, which is really to try to break as much from the past as we can, seeing what else oncology was mentioned earlier is out there as an example. So as you may have seen when the animation was coming by there, some articles there on the left, 2008, 2018, the results from very prominent meta-analyses, where in 2008, Irving Kirsch looked at all of the antidepressants that were submitted to FDA and did a meta-analysis, not just of published, but unpublished data, and found that there was a small effect size between drugs and placebo. The conclusion in the lay press was that these drugs don't work. Andrea Cipriani in 2018 did pretty much the same thing with more advanced methods and came out with a conclusion that the same newspaper memorialized as in fact the drugs working. But in reality, both of these actually had the same exact effect size. And this was meant to really illustrate our own change, going from in 2008 feeling like these drugs work and then our hopes being dashed, and now our hopes being so low that any evidence of effect is reason to celebrate. My argument is really that perhaps this is a misplaced focus, and our focus should be on understanding why the effect size is so small in the first place, and perhaps the future state, the desired future state, is just to completely end one-size-fits-all psychiatry in terms of treatment development and use, and really adopt what oncology has done, which is more of a precision approach for everything. So let me give you an illustration of how this could work. This is from a recent set of papers we've published on an NIMH-sponsored study called EMBARK. EMBARK is an antidepressant treatment prediction study that took 300 depressed patients. You can see in the panel there, the left-hand graph, gave them sertraline or placebo, and sertraline was found to be nominally better, 42 versus 34% response rate. So not very impressive. What we did, though, was ask the question of, is it the fact that the drug is not effective at all, or the fact that our diagnosis is imprecise? That's really the issue. And so we developed a novel machine learning method, trained on EEG data given prior to the treatment, and found a pattern that was strongly predictive of sertraline and could differentiate that from people who responded to placebo. And if you look at the figure on the right-hand side, this is now stratifying people based on their cross-validated EEG-based prediction of sertraline response, and what you can into percentiles, the lowest quartile, middle quartiles, and upper quartile. And what you can see is that very clearly only a minority of people are responding to the drug. They have the highest quartile based on EEG, has a almost 70% response rate, double that of placebo. So there's important lessons there, not only that there are people who respond really well to these drugs, and these drugs are actually very effective. It is our imprecision in diagnosis that's the issue, but that we're driving effects of drug or device-based intervention studies based on tiny subgroups out of the whole population of patients. And so the hope for the future state is really an end to current pharma as it is in psychiatry, and in opening the door to how pharma is in oncology, which is developing a drug for a group of people based on an understood approach and set of patterns. So I'm going to stop there and let Corey take over.
Thanks, Meet. I'm just going to say a few thoughts about the challenges for implementing biomarker research in clinical care. When we think about our future state, we really aspire to have our research be real-world, multimodal, large-scale, and longitudinal with minimal patient burden. This will allow us to develop novel, powerful biomarkers and treatments. Unfortunately, it's not that simple, and implementing biomarker research is really a balancing act. When we think about real-world research, we want our research to be as generalizable as possible, but in the real world exists high complexity of disease and comorbidity. So keeping it scientifically rigorous is not a simple task. Do we utilize strict versus loose inclusion-exclusion criteria? Do we undergo naturalistic data collection or randomized clinical trials? When we think about multimodal, which biomarkers do we use? There are many at our disposal and many that relate to mental health, including EEG, MRI, genetics, passive digital biomarkers. The list really goes on. When we think about patient burden, how do we maximize the frequency of assessments and quality of biomarker collection while minimizing patient burden? And finally, analytics. How do we combine different biomarkers with different timescales, sizes, and dimensions together in a meaningful way? In all, for the future state, finding that right balancing act is critical to keep scientific rigor and patient satisfaction high while minimizing costs and patient burden.
Excellent. Well, thank you so much, both of you. It's very exciting. Next, we're going to move on to Timothy Mariano. Timothy is a medical director in late-stage clinical development at Sage Therapeutics. He's also the associate investigator and staff psychiatrist at the Center for Neurorestoration and Neurotechnology at the Providence VA Medical Center in Rhode Island. Tim.
Thank you. It's a pleasure to be here with all of you this morning. So I'm going to talk about two interrelated aspects that I think will be predominant in the future, involving digital mental health tools and also rapid treatments in psychiatry. And really that underpins sort of two aspects of what I think our future vision, our future state may entail. I expect that we'll see a movement away from sort of more traditional and, if you will, low temporal resolution measures, such as rating scales that can capture a patient's state at discrete time points that may be weeks or even months apart, and that those will be replaced with digital biomarkers, including continuous biobehavioral data. And this will be backed by a near ubiquity of the hardware, including not only mobile devices such as telephones or fitness trackers, but also integration into everyday objects, which might include jewelry, clothing, even medication tablets or packaging for food products, all providing the potential for data that must be weighed, of course, with appropriate ethical considerations. In line with this, in the future, we'll probably also see a movement away from traditional antidepressants that may take on the order of 2 months to show effect to more rapid acting treatments that can demonstrate meaningful clinical difference in perhaps days to weeks. And these could include non-invasive brain stimulation technologies. I give a couple of examples on the slide of current and emerging ones, but also novel pharmacologic agents such as esketamine and brexanolone, two recently approved rapid-acting antidepressant treatments. The eventual AI ecosystem will be challenged to juggle stakeholder priorities that may at times be competing. I try to break this down along a couple of dimensions here. Treatment developers, that'll be the scientists and companies that are involved in developing these treatments, will need rapid predictors of response or non-response to their candidate modalities. Today, we do use digital health tools in clinical development in the biopharma space, but oftentimes they're included at phase 3 or post-marketing, which I would argue is too late in the process. They really should be integrated much earlier. Also today, inclusion of those tools usually adds substantial burden for sponsors, for sites, and for patients and participants. There's usually an additional app that must be installed, additional devices that must be carried, additional visits, additional data entry. And also competing goals for what the treatment developer wishes their eventual device or technology or medication to have in the marketplace. One is, with a digital health tool, is it a purely diagnostic tool, a therapeutic tool, or some combination of both? And that must be weighed against the candidate treatment and whether that will be purely a monotherapy treatment or an induction treatment or an augmentation treatment. All of these would affect how we might want to integrate such tools. Providers and payers, of course, will want an early warning system provided by the AI ecosystem to identify patients who aren't doing well and to suggest alternative treatments. And last but not least, the patients themselves will want an AI ecosystem that not only provides some information that they might be doing worse, that may be important in diseases such as schizophrenia or bipolar disorder, where sometimes patients do not have complete insight when they are starting to do less well. But patients may also want some therapeutic option, for example, some provision of stopgap treatment to bridge them until they're able to see their provider either virtually or in person. And that could comprise web-based CBT bots or online group teletherapy, to give two current examples. Thank you.
All right, thank you so much. So now I'm going to hand it over to Andy to introduce the remainder of the speakers, and then we'll move on to a discussion of the future vision. Andy.
Thank you, Justin. Our next speaker is Brian Shiner. Dr. Shiner is a staff psychiatrist at the White River Junction VA Medical Center and assistant professor at Dartmouth Medical School and the Dartmouth Institute for Health Policy and Clinical Practice. He's been involved with research at the VA Medical Center evaluating the effect of a new primary mental health care clinic on access and quality of depression care, and has completed multi-site research using performance measurement and interview data to evaluate clinical processes that promote higher quality and improved efficiency. Dr. Shiner?
Yeah, Dr. Crystal? Hello?
Yes.
You can hear me now? Okay, great. So thank you, Dr. Crystal, for using a bio from 10 years ago, because that gives me a picture from 10 years ago when I had hair. So that's really pleasing to me. My desired future state for the healthcare system and for the VA in particular where I work is that we leverage the data produced in routine practice to learn and to plot our path forward. And I'm not the first person to say that. The IOM and the National Academy of Engineering 15 years ago said that in their report and called it a learning healthcare system. And certainly the IOM CER report a few years after that kind of said the same thing about how we should use healthcare data. I think that for me, in the work I do as a psychiatrist, I think there are two things that we can do that are important. One is to kind of look at current practice and see how it works in the real world. And currently I'm wrapping up a DoD grant where we're comparing 5 medicines that we know are effective for PTSD in clinical practice using patient-reported outcome data, as well as pharmacy data and data from psychotherapy notes on what treatments they're getting for PTSD at the same time. And looking at not only the effect overall, but in specific clinically important subgroups such as women, people with traumatic brain injuries, and so forth. So from that work, we're kind of moving into a new area of research, which I hadn't really imagined up until about 2 years ago when I started to write a R01 with my colleague Jamie Gradis. We're going to use the data that we've developed for our DoD funded study, which is about 2 million patients with PTSD in the VA from 2000 to 2019, about 20 years of data. 500,000 have pre-post outcomes information about their PTSD called the PCL. We're going to look at about 2,000 drugs that are FDA approved. And we'll be looking using a method called tree scan developed by our colleagues Martin Kolderoff and Krista Hubrex down at Harvard to scan for drugs and classes of drugs that may actually be effective for PTSD that we don't know about. The unique thing about our tree scan is we'll be considering drugs in terms of mechanistic classic, such as alpha-2 antagonist or whatever, rather than clinical classes that are traditionally used, such as anticonvulsants or antihypertensives. So we'll be looking at mechanism rather than what they're used for. My colleague Jiang Gui has been working with me for many years now on this DoD work where we're comparing the currently approved drugs. As we discover things with tree scan, we'll be comparing the drugs we discover with tree scan to drugs that don't appear to be effective for PTSD but are used for the same thing in order to get somewhat at our causal analysis. And then, of course, once we're done with that and we find our top candidates, we'll be doing the same thing to look at safety of the drugs that we think should be studied or used moving forward. So that's just an example. I know there are lots of different examples and thoughts about how to learn from healthcare data, but this is kind of how we're doing it. So just to give you a sense. I think I wrote 2 challenges. I think there are actually 3. The third one I can't write down. But so one big challenge is that the VA is a unique computing environment. So we have data on patient-reported outcomes that have been collected since about 2008. We have really very granular information about prescriptions and when they were picked up, when they were mailed, what the doctor said in the comments bar, et cetera. And we also have access to all notes written in psychotherapy encounters, so we can train computers to read those notes and say whether people got psychotherapy that's effective for PTSD while they were getting these medicines, for example, so we can account for confounding a little bit better. So whether that kind of data exists outside the VA is a big question on my mind. I haven't heard of other health systems having all that, although I'm sure they will soon. It's also been very challenging to share our data sets with people outside of the VA. The VA just has a lot of challenges around making sure we're protecting healthcare data at the same time that we're learning from it. So I think that's our colleagues at Vinci, which is the VA data repository, have been working on that for several years, and hopefully there'll be something coming soon. The last thing is the VA is about to go through, or is beginning right now, a transition from our homegrown EMR Vista to a contract with Cerner. And, things may be better in the end, but for a period of as many as 10 years, there may be holes in the data, and the data that we end up with in the end might be better, but it might also be different. So we might be able to ask different kind of questions, but perhaps not the same questions we've already been asking. Thank you.
Thank you, Dr. Shiner. I just want to remind our speakers, because we're running a bit behind on time, to try and keep the remarks to 2 minutes maximum. I know there's a lot of exciting points to raise here, and we'll hopefully have plenty of time to bring them up in discussion. Our next speaker is Diana Clark. Dr. Clark is an experienced epidemiologist, research statistician, and educator with a long history of working with academic institutions, specialty organizations, behavioral health agencies, and hospitals. Please go ahead, Dr. Clark.
Dr. Clark, you may be muted.
Sorry about that. Yes, I was. So I'm going to jump right in then. So one of APA's mission is to help psychiatrists and other behavioral health providers provide high quality care to patients with mental and substance use disorder. And we know that there variability in where these providers are, where they practice, variability in terms of how they practice, and then also the patient population they serve. So they have variability in terms of the access to different types of resources. And so it was part of that that actually led to us developing this national mental health registry that we've developed at APA called PsychPro. And the goal for PsychPro was to kind of bring together data from clinicians across various practices, whether it's solo practices, academia, emergency, outpatient, inpatient, and primary care, because we know that majority of patients with mental and substance use disorder do present to their primary care and get majority of their care from primary care. And so it's trying to bring together all of this data, whether it's data from electronic health systems, data from patient portals, and also with this grand idea that we'll also try for patients who agree to do this, actually also bringing data from any kind of wearable technology. And the promise of this is that if we could actually get all of these practices, different types of practices and different settings to actually join PsychPro and bring in all this data, the promise of that would be that with using all of the big data analytics, we would be able to share data not only with the patients who are providing this information, because a lot of in terms of speaking with patients, we find out that sometimes they have a problem with providing a lot of data and getting no information back. So a way that we can actually share information with patients, but then also use that information to actually develop practice guidelines, to actually create or identify effective measures of psychopathology so we can actually have improvement in our diagnostic manual or any kind of diagnosis for mental health and substance use disorder. And then also use that information to provide real-time decision support and real-time interventions to the clinicians, regardless of where they are and where they're practicing. And the hope is that this type of integration of different health systems and different data types and patients from various parts of the country, we could actually enhance the quality of care to mental health and substance use patients. And that would be because the idea is to create the system that the system learns, provide information to patients and to providers, and as we get information from them in terms of how things are working, we identify where quality of care is great versus poor, and then create learning opportunities for providers, and actually also provide resources and information for patients as well. So some of the challenges that we do see with this is, and I've listed some here, but one of the biggest one is actually challenges in bringing on some of the larger settings, especially academia, where you get into the issues, legal issues, etc. And it's not just the legal issues, because we've worked out most of those. It's where the trust in sharing data. And I know the person before talked about sharing data outside of the VA. And so it's a kind of overcoming some of those barriers, and then also overcoming barriers with the different electronic health systems and whether they're willing to allow us to integrate with their system to pull data into the registry, but not just to pull the data in, because the usefulness of this will be to actually push the data back, information back to the EHR so clinician can use that information in their clinical care. So that's one of the a couple of the challenges that we've actually faced. We also know that there are challenges as well. I mean, as part of this registry, because it was built to provide as a quality improvement tool and to be used secondarily for research purposes, then we get into thinking about the ethics of do we need patient consent? And because it's primarily for quality improvement initiative, we don't necessarily require patient consent to actually use the data to inform those things where we do require, based on the common rule, where we do require patient consent, is to get patient to consent to be recontacted for future research studies. But it has great promise in the sense that it creates a repository of data that can be used to answer a lot of interesting questions, can, as I said, drive revision to diagnosis, inform practice guidelines. But it also provides a repository of patients who have actually completed consent to be recontacted and can be available to participate in different types of research studies. And we know one of the limitation is that many patients with mental and substance use disorder doesn't necessarily make it into a lot of these research studies that have been done to date. And so I'm going to actually stop there. It's just because I'm trying to make sure I stick with the 2 minutes, and I'm hoping I didn't rush too much there.
Thank you very much. Our next, sorry. Thank you.
Those who are not speaking, please mute yourselves.
Our next speaker is Dr. Neil Ryan. Dr. Ryan is an expert in pediatric mood and anxiety disorders. He's led large-scale studies of behavioral change in children and adolescents diagnosed with mood disorders and has investigated the effectiveness of therapies. Currently principal investigator in a large NIMH-funded project related to the neurobiology of childhood anxiety and depression. Dr. Ryan.
Hi, thank you. Let's try for the 2 minutes. Look, what I want to say today is that social determinants of health really matter, and you can get those only by natural language processing of the chart. So if you've got high value predictions, you're going to have the stuff that we're talking about and talk more about, but you probably want to add the social determinants as well. You know, losing your job, becoming homeless, having marital conflict, imprisonment, and so forth still matters. I'm not saying my whole slide here, by the way. Anyway, so all of these are hidden in free text notes in the medical record. They're not in structured data by and large. You know, they're in social work notes, they're in emergency room notes in the free text. How's this been done in the past? Well, there's several things that are too simple to work well, like bag of words or word embeddings. There's a structured ways that work well in medicine, like CTAKES, the CTAKES, excuse me, clinical text analysis knowledge approach. And then there's the new approaches that started 2 years ago with the deep learning language models, BERT and ULMFIT and so forth. And those are far and away the best ways to understand sentences right now that's available in any sort of machine learning. And I think they'll become much more important in the things that we're going to be talking about today. The example that I wanted to give is David Brent Rich-Sui and I looked at predicting suicide attempt after an ER or hospital visit, a high value thing to do as best prediction you can. Using all the structured data and looking, say, for example, at the 7-day suicide attempt in the next 7 days, really important when you've got somebody in the emergency room of, you know, do you hospitalize them? Do you give them a really near-term appointment? What do you do? We got an AUC of 0.88. As you guys mostly will know, an AUC of 0.10 is, you know, an oracle, the gods predicting. An AUC of 0.5 is completely random prediction. So 0.88 is a pretty nice prediction. When we added the natural language processing data, it went up to 0.92. So that's a quarter of the distance to perfection. You know, there's actually, I'm sorry, that's 33% of it. So going from 1.0 to 0.88, improving that by 0.04 is an improvement of a third of the way to perfect prediction from what was already good prediction. The things that mattered in that one were marital conflict, imprisonment, family support, going into rehab. So lots of good and bad things that were not in the chart, were not in the structured parts of the chart, were in the free text. Why is this hard? What are the challenges? Well, there's some technical ones like completely anonymizing things, getting access, idiosyncratic abbreviations, local abbreviations. But the really hard one is that the best techniques, the deep learning language models, are exactly 2 years old in the world, not just in psychiatry or medicine. And so we don't completely know how to use those as well, and we don't have them trained up. I think that for other high value predictions, like readmissions, like starting to use starting to abuse opiates after you give them an opiate dose, like violence. There'll be things where you want to predict as well as possible. I think you'll want to add this part to it as well. Thank you.
Thank you very much. Our last panelist is Dr. Basit Chowdhury. Dr. Chowdhury is an internal medicine physician and medical technologist. His expertise is in the areas of healthcare payment, clinical service design, and the use of data analytics to improve clinical and financial performance in healthcare. He works to develop more scalable ways of delivering healthcare, founded Tuple Health in 2013. He's also been a lead research clinician at IBM Research. Please proceed, Dr. Chowdhury.
You may be muted.
Sorry about that. I apologize. So again, thank you very much for the opportunity to have this really interesting discussion. Just by background, I'm a primary care physician, so a lot of my perspective on mental health is really from that context. Much of my work now involves working with high complexity patients, and it's very, very common that they have an overlap between their medical conditions and their behavioral health issues. I think in many ways that distinction is very artificial, particularly given limitations in access to care many patients around the country have to psychiatry specifically. So just in terms of kind of the vision, I'm just going to try to read some of this just to try to stay on time. I've kind of divided it into kind of broad, kind of a broad lens, and then more specific related to techniques from machine learning or narrow AIs. I kind of designate it here and talk a little bit about challenges. So kind of broadly, just in terms of a vision, from what I see for mental health and behavioral health issues. Broadly, is to develop a learning system for mental health in which generalizable causal inference is deepened and broadened across the clinical enterprise in a continuous, repeatable, scalable, and cost-effective fashion. Here, clinical decision-making and process execution will be enriched by causal explanations, which progressively improve through feedback loops involving care delivery itself. These feedback loops will be operationalized through technologies that systematize quasi-experimental methods and extend them into the clinical enterprise, democratizing the rigor from the research setting into practice. I think a major part of here, which I'm excited about, is the way in which different kinds of insights can feed back into and generate new theories and enhance theory development. I think it's a major part of generalizing causal inference, obviously. Broadly speaking, these hybrid care delivery and quasi-experimental platforms will address threats to validity through two primary mechanisms. One is through structural design features. I think in many ways, as the discussion in healthcare and broadly in society increasingly focuses on data, I think in many ways we are not focusing enough on structural design features to address bias. How do we systematize those? And I think secondarily, we have obviously a variety of different quantitative techniques and modeling methods through which you can minimize the reducible error inside of models related to picking different kinds of functional forms. Related to this within the context of, again, narrow AI, so to speak, again, my comments are outside of any kind of generalizable kind of notions of intelligence that can be instantiated in machines. I think we can, in theory, make meaningful advances across multiple fronts, particularly around counterfactuals, quasi-experiments, designing more relevant controller comparison groups, and rendering different types of functions or mathematical functions for modeling purposes that specifically change the variance bias trade-off that we're usually forced to make, much of which is just generated by advancing computational power. The challenges to this, I think, are quite significant. I think one broadly right now, given that there's often not a definitive pathognomonic constellation of signs or symptoms for mental health issues, that creates a lot of complexity in terms of data quality and data annotation for supervised learning methods and related techniques. I think there's a very limited adoption of psychometrically validated instruments, particularly within the clinical enterprise, and that really diminishes the quality of the data we have. Construct validity is, I think, an enormous challenge in this field in particular, and something I get quite concerned about because we often don't know exactly what we're modeling. Broadly, data quality, clinical data modeling specific to mental health, issues of selection bias, omitted variable bias, all these things that we see when we work with existing data sets. So that's kind of broadly, I think one other thing I'll just kind of mention, generating ground truth for algorithmic training is incredibly difficult. I think it's going to be especially difficult in mental health. both in terms of its cost and complexity. And finally, I'll just mention, I think algorithmic interpretability. We really want to change a clinical inference. I think my fundamental assumption is that causal inference through explanation is critical to that. So I think the interpretability of what we produce becomes especially important. So I'll just stop there. Thank you.
I just want to do a time check. We now have the remaining 15 minutes of this session for discussion to be moderated by Justin Baker and Andy Crystal, our co-moderators. And also to remind the attendees, you can insert your questions in the Q&A box, and Adam Thomas will be curating and bringing those questions to the panel. So handing it back to Justin and Andy.
Thank you, Holly. We've heard about a fair number of different perspectives on what the future vision looks like. And it's clear that there are a lot of different components to this. I'd be interested to hear from the panelists about their perspectives on the other talks or presentations they heard and how they impact on their view of the big picture down the road.
Yeah, hi, this is Brian Shiner. I talked about VA data. I was curious, a few of the presenters talked about deeper learning approaches than we're using basic tools.
Hi, Annie. Hi, Sam. Hi, Emma. Hi, Reese. Hi,
So AEW gets the award for the first of using intrusion. Please mute your phones.
Oh, okay. I'm sorry. So, well, I was just talking. So we're using more basic ML techniques like, random forest and lasso and things that have been out there for a while. And kind of the challenge for us for thinking about those deeper techniques is kind of managing the data is such a task in itself and getting the data clean. Are you guys finding that you need to have less clean data for these more deep techniques, or what? How are you managing, spending all your time on ML when there's so much data management to do?
Would one of the panelists like to respond to that, or one of our?
Please feel free to unmute yourself if you want to participate in the discussion, and because you're all probably muted at this point.
I can. So yeah, Brian, on your point, just I guess from my experience, I think it's difficult to overestimate how important essentially the data management component of all this is. I wish obviously that weren't the case, but I think if anything, we don't pay enough attention to it often. I think in areas that are very discrete, like computer vision and things like that, where a lot of the focus has to just by the nature of the field of the domain, people have not had to focus on that as much in a certain way. I think it's just very difficult within domain-specific applications, particularly ones which are knowledge-intensive, that data management and clinical data modeling, I think, just is a fundamental part of deriving, I think, better predictions and, more importantly, I think, better causal inference, which is what I think most directly impacts patient care.
If I could try a short answer to that one. This is Neil. Clearly, for panel data, lots of people are going to extreme boosting, which may be a little bit better than the random forest, but is similar, whatever. The deep learning stuff, which gets, a lot geekier, is valuable for imaging data or image-like things, for long time series data, time series-like things, and for language. And, probably almost certainly will be enough better that it's worth doing. But it does get more complex by a whole lot. And none of it makes the data cleaning and preparation a bit easier.
Thanks. Those are great answers. Thank you.
And Adam Thomas, you may want to bring forward some of our questions from the attendees.
Yeah, we've got a couple questions, and I'd encourage folks to type any more questions they may have into the into the question box. The first one is focused on the data collection question, that we need to be aware that this useful data will need to be added to clinical patient meetings. Patients already have a problem with clinicians' split attention between them and the medical health record. Improving the medical health record is important, but is this problem on the radar? This comes from Ray DiPaolo. Sorry, I didn't decide who to direct that to. Andy, do you want to take that one first?
I'm sorry, were you directing it to Andy? Is that what you said?
Yes.
Oh, okay.
Or unless you wanted to redirect it to another.
Well, is anyone on the panel particularly inclined to answer that?
Yeah, this is Tim Mariano. I think I'll just say one thing very briefly. I agree, right? Adding burden not only to collection of the data but also to the patient visits as well. I mean, I think the last thing that most clinicians will want is another dashboard to check and review, either before or during the patient visit. So, these tools, while great, also need to be minimally intrusive to the critical patient-clinician interaction. And whatever can be done on the back end to assist that, I think, will be important.
Yeah, this is Justin. I'll just add to that. I think one of the things we think about as treaters is there's multiple purposes to a clinical encounter. Currently there's an information gathering component to that, obviously, but there's also a relationship building component. And yes, what's the purpose of that relationship building? Partly it's, we know that the therapeutic alliance helps people buy into treatment and keep people sustained over longitudinal periods. And so I think it's going to be really interesting to ask the question of, for the amount of money we're paying for particular bits of information, what is the actual cost to information quality relationship for all the types of encounters or biomarkers we could be capturing? We heard this morning from, using EEG, using, the trails from the EHR, which of course come from those visits. We're going to hear, from other types of biomarkers like wearables. And, if you think about the information content of those things, they may be worth more, so to speak, than that hour-long visit with the clinician, and yet there's still some value to that relationship building component, but it's not clear necessarily that we need to be thinking about the MD necessarily being the one in every case to maintain that relationship. But I think we're going to have to kind of radically rethink models that we provide care in, where we can really balance information and sort of prognostic value against these kind of tried and true methods of patient-doctor relationship, and really trying to strategize now in the access high and resource poor environment where we have far more need than we will ever have treaters available to spend minutes with people. So I think we're going to be talking more about that future state. Is it one where traditional psychiatrists are providing that hour, or where we have sort of networks of humans who can provide that one-to-one patient contact and other methods to buttress kind of the information gathering piece?
This is Diana. Sorry, this is Diana Clark. So one thing that I'd also like to add is I really do believe that one thing that we need to do is to bring the EHR company to the table as well, because if we can't try to integrate all of these things with the EHR, we will always have the clinicians and or the patients moving from multiple platforms to get the information that we need. And these are valuable information to actually inform their treatment and the patient care. But if we don't bring the EHR companies to the table and actually work on something so we can integrate these systems, we're going to always have this problem. And so we will always only get a piece of the data to do anything that we do, and we'll always be missing pieces of information.
I'd like to second Dana's point there. It's very important. And a way of integrating the information from data streams into clinical care at the patient encounter. And we're delighted to have a couple of representatives from one of the EHR companies with us today, from Epic, who'll be participating in session 3. All panelists across all sessions, please feel free to chime in during the discussion sessions if you'd like to make a comment.
Maybe it's helpful to go to Olu Ajulori's question. Olu, you want to just go ahead and unmute yourself and ask the question about kind of ensuring that all of these new innovations are able to make it across the digital divide?
Yeah, so attendees may not be able to unmute themselves, so we'll be reading questions from the Q&A box.
Okay, no worries. So yeah, Olu's question is, any thoughts on ways we can ensure that the future innovations are available to underserved populations such that the digital divide doesn't become a digital mental health divide? And maybe I'll point that question at Meet.
Yeah, so thanks for the question. I think that's a really important issue, because I think we often do look at things from the lens of research, where we have a lot of resources, and hospitals that do research tend to have a lot of resources, and that's a major limitation. I think as we think about what the tools are, we also have to think about what the tools are providing. So far, as we think about these digital mental health tools, there's yet to be really strong cases for what what they really add. However, let's just think of a canonical example of a smartphone-based tool. If it's something that becomes useful in part because it saves money for health systems, and that's really the route by which insurance companies and federal insurers will adopt things, because it ultimately leads to better care but saves money. Part of that has to be thinking about the equipment and having accessibility as part of that. That has to be part of that financial equation. And I think as cheap as these things are becoming, it's now becoming quite feasible to provide smartphones. There's programs for elderly and low-income people, for example, giving them smartphones with data plans. So I think that those things are overcomable. We just have to think of that as part of the package, exactly as you raised it.
And I think there's no question that at this time, even in the past 2 weeks, people who didn't have a cell phone or a tablet or some access to the internet, there's strong consideration at multiple levels to get all of those new technologies into both conventional care settings, even inpatient units, where cameras and other things haven't, because of privacy concerns, been the preferred mode, but now that's being considered, which is both exciting from the standpoint of accelerating the move towards telehealth type solutions that would work if all you have is a device, but it's also rapidly raising some of the ethical considerations. So I'm excited to hear more about that later today. So we have about 4 more minutes.
I was going to just say something really quickly, Dr. Clark. Yeah, this is really very, very important to me. And one of the studies that we're currently doing through the APA Mental Health Registry, which is a quality measure development project. And one of the things that we do find is that a lot of a number of patients don't have access to the internet, so they're not able to participate. But we also have to remember our patients as well and realize that their level of comfort with technology is also a barrier that we're going to have to overcome. And so how do we reach out to patients, mental health patients, speak to them in language that they can understand so they can feel comfortable using it? So it's not having access to the internet, but it's also patients basically saying, I don't do the internet, I don't complete anything that has any access to anything. And so how do we overcome that barrier so that the information and the data that we're collected is really generalizable to all the patients, all patients with mental health issues, mental and substance use issues.
I have a question for the panel. The presentations have all described a number of different types of data that are likely to be important in the future vision, and from lots of different sources. Be interested to hear what people's vision is about how integration could happen. Do people see let's say, the NIMH as having a role in this, as somehow being a clearinghouse for data and predictive algorithms? Appreciate your thoughts on that.
Yeah, and I'll also just maybe open it up, since I know we have just a couple minutes left, but to ask sort of more broadly, what's going to be the role of industry versus NIH in sort of maintaining those large data sets? Because I think there's lots of companies whose job it is to maintain large data sets. It's not traditionally the domain of healthcare, although be curious what panelists think about maybe in 5 years or less, what is going to be the distribution of responsibility around these issues?
If you're speaking, you may be muted. I was wondering if Bassett might have a view on that question.
Mute. Sorry, I had to change locations. But yeah, I think if you look at, for instance, like some of the kind of different techniques we've talked about from machine learning and different forms of quantitative techniques, like things like deep learning, the advances made in those fields have been driven largely by two things. It's interesting. A lot of the algorithmic work in those areas is quite old. I mean, dating back to like the 1980s. The advances that have recently been made that allow people to do the kind of sophisticated, say, natural language processing that we talked about before, really falls in two things. So one, it's the implementation of computationally intensive graphics chips. And then two, large corpuses of well annotated data. So for instance, in computer vision, one of the major reasons why so much progress has been made is the data available through ImageNet. So without high quality corpuses of data that are well annotated, and I can't focus or emphasize that enough, it is very difficult to train algorithms in sophisticated ways for domain-specific applications. So again, a lot of the innovation we see now is literally related to data available through ImageNet that's been annotated by humans.
Wrap up quickly. Is that okay?
Yes, go ahead.
So thank you, Bassett. And I completely agree that annotation is really one of the next key roles for healthcare in terms of thinking about the problem going forward. If you can't measure it, you can't manage it, and we're seeing maybe an influx of a measurement culture in psychiatry, which I think is a really good thing. And I think it's been present in oncology and every other branch of medicine. I think what we're all talking about today is this new cadre of data types and willingness to measure things in psychiatry that hopefully in 5-10 years or maybe sooner will allow those learning systems to begin to churn on that data and iterate and develop novel therapeutics. So thanks everyone for providing their exciting visions for the future of the field. Thank you also to my co-moderator, Andy Crystal, and all the panelists for taking the time, as well as everyone listening. So I'll turn it back over to Holly, who can take us to the next.
Thank you very much. And I think that's a good segue. Now that we've talked about where we'd like to go to achieve a health system that's able to provide effective mental health care for all patients, wherever they receive their care, and one that takes into account the social determinants of health. The next session, we're going to look at where we are now. What can we learn from existing networks? And I'd like to introduce our moderators for this session. Guillermo Sapiro is the Pratt School Professor of Engineering at Duke University, and he works on topics of theory and applications in computer vision, computer graphics, medical imaging, and machine learning. Also like to welcome Dr. Helen Egger, who is chair of the Department of Child and Adolescent Psychiatry at NYU and an innovative researcher employing new technologies to advance mental health care, especially for integrated pediatric mental health. Dr. Sapiro, please take it away.
Thank you very much, Holly, and thanks everybody for participating. As you can see, we have a very prestigious team of speakers and discussants coming up in the next 45 minutes. We have 5 minutes for each speaker. That will take us about 30 minutes for the first part, and then 15 minutes for discussions. Using every speaker, which takes a bit of time, we will let them use all the time. You can see the very prestigious speakers that we have now basically on the slide. They're very diverse, and each one of them is a renowned expert in the field, and they come from multiple institutions. So we are, as I said, we are not going to use of their time to present their bio, so we can give them the time to give us and to educate us. We also came with a few guiding questions with Helen that Helen is going to present next before we move to the speakers. Thank you and stay safe.
Thank you, Guillermo, and thank you to Holly and the rest of the organizers for including us in this wonderful conference. We had some questions that we wanted people to think about as they were listening to each of the presentations, and many of them have already come up in the first session. So we put them in sort of three buckets. The first is around these questions about data acquisition and curation, or the structural design features and data management. So where does the data come from? How is it measured? Who are the subjects? And importantly, I'm speaking as an epidemiologist, what is the sampling frame of the subjects who participate? And then issues around data combination, integration, and also was brought up data management. I think the question of how we combine multimodal data, and particularly over time, is a key challenge. How we deal with missing data, and then how do we test the clinical significance of our results in the population we created it for, but then in other use cases. And particularly came up before and is an interest of mine around health disparity populations. And then lastly, the huge challenge of bias, which comes in many ways. We give one example here about how often the mental health information is incomplete in the EHR, and there are many other examples. And then always the pesky question of how we distinguish between correlation and causality. So that's the frame. And now I'm going to hand it back to Guillermo to start our speakers.
Thank you very much, Helen. And as we say, we have 5 minutes per speaker. So Aziz, you're first, and we hopefully will not have to give you the 5 minutes warning because you're all great, but I apologize in advance if we do. Thanks.
Thank you very much. So thank you, Dr. Lizanbe, Dr. Gordon, and thanks for all of you for the opportunity to be here with you in such a great workshop. So I'm an oncologist. I treat cancer patients. My specialty is treating a form of blood cancer, is myelodysplastic syndromes. I also direct the Center of Clinical AI, so we do use AI and machine learning, deep learning to try to solve some of the challenges that we have clinically. So just to give a quick background about the disease, this is a form of blood cancer that happen in the blood. The average age of diagnosis is about 70. The way we make the diagnosis actually by doing a bone marrow biopsy and try to put this experienced hematopathologists can look at the slide and give us the answer whether the patient has myelodysplastic syndrome or other form of blood cancers. And then the next step of any cancer is to kind of stage the disease. And this is kind of a blood cancer, so we don't do CT scans. What we do is just take the blood counts, look at the patient chromosome, plug them into a scoring system, and then come up with risk scores that this patient is a higher risk of progression to advanced stages, and lower risk. And this is a very important step because our treatment guidelines are based on risk. So if patients has a higher risk, we tend to give them more aggressive therapy compared to patients with lower risk. So what we found, what you see on this slide, several of the challenges that we have clinically, and then the question, can we solve those challenges using machine learning and deep learning? So one of the biggest challenges is the diagnosis of the disease is very subjective. So about third of the slides, of the bone marrow slides, come to us from the community oncologists. They have misdiagnosed the disease, whether they told the patient they have MDS, but they don't, and vice versa. So what we have done so far, we took some of the pathology slides, and using computer vision, we've been trying to say, is this MDS versus non-MDS? And we have very exciting results that's not shared yet. But the other project that you can see on the lower slide is looking at the blood counts and the genomic signature from the patients. Can we build a machine learning model that can differentiate MDS from other myeloid malignancies? We have done this project where we actually compared MDS to other, what you see here, other myeloid malignancies look exactly like MDS. What we able to find, actually, we built a machine learning model that achieved about area under the curve of 96%, differentiating MDS from other diseases just using clinical variables and mutational data. So you could envision future of not doing bone marrow biopsy. The other thing in terms of prognosis, what we found that what we are predicting in terms of the staging system, but the actual survival of the patient is completely different. So we have used machine learning to take clinical data and mutational data and build this model that can provide personalized prediction. And if you can click here, this is supposed to be a video. If you can click on the actually play, you can see me here changing some of the clinical variables of the patient, make the patient actually worse, and then you can see the survival probability of the patient, it changed. So this is just to talk about, personalized prediction that are specific for a given patient. And finally, we have used also some machine learning and technologies trying to predict response to chemotherapy. So one of the chemotherapy that we give to our patient is called hypomethylating agents. Today, we don't have any models to give us an idea which patient would respond or not, and it takes about 6 months of patients to achieve a response. So one of the projects we did, we took actually the recommender system algorithm, saying if you watch this movie, you're gonna watch this movie. If you have this gene, or this gene, you're gonna respond or not respond. Based on that algorithm, we developed genomics biomarkers that can predict resistance in about a quarter of the patient, but when they present, their accuracy of prediction of resistance was about 93% on an independent validation cohort. This was also validated in the lab where we used the CRISPR-Cas technology to knock out those genes, and we generated those cells in the lab. And finally, one of the projects we're working on now is using time series analysis. So sequence in sentence matter. When we give chemo, the blood counts change over time. If we monitor the change in the counts over time, can we predict response or no response? We were able to build a model that actually just monitoring the changes in the blood counts on the CBC, we were able to predict the patient who's going to respond to chemo or not with 83% area under the curve. So these are some of the examples that we have used different type of technologies in machine learning and deep learning at different domains, trying to improve our tools knowledge and clinical decision-making tools that help our MDS patients.
Thank a lot, Aziz, and thanks a lot for keeping the time. The next presenters are going to come in tandem is Greg Simon from Kaizen Permanente and Rebecca Rodson from Health Partners. So they're going to take one after the other, 10 minutes. Greg, please go ahead. Thank you very much.
Actually, Rebecca's taking this first part.
Oh, okay. So then, perfect. Thank you. Thanks. So it's your 10 minutes. You two together are leading the next 10 minutes. 9.5 minutes.
Okay.
Thank you.
We'll do that. So this is Rebecca. Greg and I are from the Mental Health Research Network, which is a consortium of 14 research centers embedded in large comprehensive health systems. Together, we serve a population of about 25 million people across 16 states. And sort of related to the conversation earlier, we all do use Epic for our electronic health records. So we each maintain a data warehouse following the Sentinel Picorinet common data model and consolidate our data that includes electronic health record data, insurance claims, pharmacy dispensings, patient-reported outcomes, lab results, demographic characteristics, insurance coverage characteristics, and mortality when we link up with state mortality records. So using these data sets, then we have done some work to develop suicide risk prediction and really have worked to predict suicide risk accurately and relevant to the point of care. We can estimate risk for a specific customer So we have developed validated models predicting suicide attempt and suicide death after mental health specialty or primary care visits. And now we're working on developing models for ED visits or patients after inpatient stays. Next slide, please. So for this model, we use 25 million visits for 4 million patients and develop models that have an overall accuracy or area under the curve of 84 to 86%. So that's what we have. What we'd like to see is more accurate coding of self-harm events. To the discussion previously, you know, we recognize the models are as good as the data we can put in it. And the more we can minimize those false positives and false negatives, the better models that we'll have. We'd also love to have better up-to-date social determinants of health. So things that aren't routinely collected in the EHR or are not routinely updated, but can have significant prediction for suicide attempts, things like job status, relationship status, food and housing security, for example. What we don't think we need is more complex or opaque modeling strategies. You know, we have evaluated alternative modeling approaches, including classification or tree-based approaches, classification and regression trees, mixed effect regression trees, random forest plots. But honestly, so far we found that the simpler models are nearly as good. We also don't think we need new model development for every healthcare system. And we're not letting the perfect be the enemy of the good. In our care systems, mine and Greg's, our suicide risk model has already been implemented, and that happened within about 6 months of publication. In my healthcare system, by the behavioral health case managers in our health insurance arm in Minneapolis, and within about 9 months in a pilot behavioral health clinic at Kaiser Washington in Seattle. Next slide, please. Additionally, a tribally owned and operated healthcare system serving over 65,000 Alaska Native people in Anchorage and 55 rural villages took our model predicting suicide attempt after a primary care visit and revalidated it in a sample of about 50,000 visits in their clinics. And this table shows results from that revalidation. And you'll see that the positive predictive value was a bit higher, reflecting a higher prevalence of high-risk patients, while the sensitivity was a bit lower, overall suggesting good usability in a very different healthcare system. And this healthcare system is now also developing an implementation plan. So I'll turn it over to Greg.
Thanks very much. Could you go on to the next slide? So I'm going to shift a bit and talk about some of the work we're beginning regarding developing personalized treatment pathways for depression. And by way of introduction, I should say that Roy Perlis and I literally 10 years ago wrote a paper about what we needed to develop personalized care pathways for depression, making the point that we thought traditional randomized trials were not getting us there and would not likely get us there. And we said what we really need are comprehensive data on treatments and outcomes coming likely from large healthcare systems where we could have the data volume necessary to answer some of these questions. If someone had told me 10 years ago, Greg, 10 years from now, you will have made almost no progress on personalized depression treatment, but you will have accurate predictions of suicidal behavior, I would have laughed out loud. I would have thought that the likelihood of progress in those areas was exactly the opposite, but that's where we are today. So a few words about sort of, you know, maybe why it's been a bit slower getting started on the personalized depression treatment. So what we really want are, oops, back to the previous slide. Okay, so what we want, we would like patients and clinicians who are selecting treatment for depression to have accurate and constantly updated personalized predictions, essentially to say for someone with your characteristics, those characteristics being your own patterns of symptoms, patterns of co-occurring conditions, your history of response to various treatments, and even other sort of omic data that might soon be available in electronic health records, this would be the next step for you. And I'd say where we are now is we're just getting started. So maybe you could go on to the next slide now. So in terms of what we have, you know, just looking at, say, 6 of our health systems that have, I'd say, made the most progress in terms of systematic collection of outcome data, We have a database that includes about 1.4 million people who've received some pharmacotherapy for depression just in 1 year in 2019, where we have comprehensive data about their exposure to medication treatments for depression. And this is, come online within the last 2 to 3 years, relatively complete data regarding outcomes. So the database regarding outcomes in those 6 healthcare systems includes longitudinal data about 3.6 million PHQ-9 depression score observations for about 1.1 million people. What we find in these healthcare systems is people initiating treatment typically have a standard, typically the PHQ-9 depression score recorded about 85% of the time, and have outcome scores recorded typically 60+% of the time. The failure to collect outcome scores is, as many of you know, not because people are seen and outcome is not assessed, but because people drop out of treatment. So what do we need to really move forward on this? Interestingly, we have very good data on outcomes. We have really poor data on adverse effects of treatments. We may know that medications are discontinued, and even when we try to mine text data to find out why and what particular adverse events people experience, they're poorly recorded. Although we can characterize pharmacotherapy fairly accurately, all we can say about psychotherapy is that a visit occurred, and to be honest with you, a bill was paid. We can say very little about the actual content. We would really like to have more useful data regarding the logic of treatment decisions. That may sometimes be recorded in free text, but to understand when a new medication was it prescribed because of adverse effects? Was it prescribed because of lack of effectiveness of a previous treatment? We'd really like to see that recorded in a systematic way. And then the analytic challenge here, I think, is different from, the challenge of suicide risk prediction, where we really can use, I think, fairly standard and well-established methods for a yes-no discrete outcome and a fairly well-characterized vector of features or predictors. Here, we're really trying to discover treatment response phenotypes. We're trying to understand what patterns actually exist in nature of responses to different treatments. The number of patterns is quite large, especially when we consider the possibility of order effects, that in what order people were exposed to different treatments may matter or predict in terms of subsequent outcomes. And we really are moving just from prediction into causal inference. So we're having to combine a sort of pattern discovery activity with a causal inference activity. That gets fairly complicated, and that's something we're just starting to think about. We do have a couple people in our network who are working on these methods quite actively right now. So that's my sense of, maybe why we're not quite as far along in the personalized treatment, but what we're hoping to develop. I'll stop there. Thanks.
Thank you very much, both Rebecca and Greg. And we are going to move to the other side of the ocean to Matthew to talk about
Janssen. And the idea of this is really to try and get a handle on people's sort of 360-degree view of people who experience depression and try to predict depression outcomes using mobile technologies. And if you look at the diagram at the bottom of the slide, the current state of play in most health systems and most research is that we get snapshots. We get snapshots of people over the course of a long period of illness. Depression is a chronic disorder. It relapses and remits. And we simply have these little snapshots in time, usually only when the person has got a diagnosed disorder, not before. And usually those snapshots are entirely dependent on them being unwell and seeking treatment. In the challenge for mobile health is to be able to provide a continuous, pervasive stream of passive data, as well as some active data, which can give a very well-rounded indication of many of the higher functions of the central nervous system, including sleep, activity, sociability, cognition, speech, and mood. And we do this using a platform we've developed in Radar CNS, which both takes passive data from a smartphone. This will include things like GPS, also wrist-worn wearables, and in fact we're using a Fitbit in this study to give actigraphy, and also active tasks, questionnaires, little bouts of experience sampling, and cognitive and speech tasks. The radar, so radar is actually active in 3 diseases. We're doing this in epilepsy and MS, as well as in depression. But for the depression study, we're just about at the brink of having reached our recruitment target of 600 participants, followed for up to 3 years over this time, with data coming from Android smartphones and Fitbits, with intermittent web-based interviews, and also more detailed qualitative interviews on their experience of the study. So the aim of this study is really to try and identify biosignatures which are indicative of relapse. But it's a very naturalistic study. It's a study which is taking people at all different stages of depressive relapse and remission, and following them over time in as unobtrusive way as possible. Next slide, please. So next slide, please. Yeah, great. Okay, so I was asked to sort of highlight some of the questions and issues and how we've tackled them. We've been running, I guess we've been data collecting for about 2 years or so. And the first question, I think it's really important actually in this whole seminar, I haven't heard enough of this, about the patient, the participant, and their experience, because all these technologies are profoundly, they require assent or consent for data to be used. They have implications around privacy. In the Radar CNS program, we're asking people to give us GPS data, which is obviously highly personalized. We do that by obfuscating it, but still the issues around privacy and acceptability are critical. So we have had a really serious, intensive periods, and it's ongoing in the study, of public and patient involvement, and a very active patient advisory board. We have a lot of qualitative work. We did a very sort of detailed workshop with patients and participants about what they would tolerate in terms of device selection. So we're asking them to wear a device for 2 or 3 years, what matters to them. And what matters to them might be quite different to what matters to researchers. So in fact, we went to a consumer-grade device rather than a research device, because we wanted to make sure that participants had something which didn't feel stigmatizing, that was easy to use, the battery life was reasonable, and so on. Whereas the research-grade devices, where we might have been able to get raw data off the device, had more difficulties in those respects. There's also a need for technical support, and actually in the mobile health field, certainly when we were starting, it was actually quite difficult to find a platform which did the job for us. What we wanted was something which was device agnostic, so that you could plug and play new devices into it. It wasn't sort of caught up with a particular manufacturer's device. And we built this. We also, I think, made the decision to make it open source, and by doing that, you actually make it far more sustainable. It doesn't just last the length of the project; it actually has a life beyond that. So there is, if you want to look it up, a platform called Radar Base, which is used for this study. There's also, I put there, technical stuff happens, because actually when you're doing this, you're not in control of a lot of technology. During this time, Android changed their operating system. It stopped us from being able to do some things which we were taking for granted that we could do. Suddenly notifications weren't getting out to our participants. And you have to have a very kind of nimble way of identifying problems and fixing them in the middle of a study, in a way which most studies I've worked on in terms of protocols is just not something you normally experience. Another issue is future adoption. So we want this to get out into the real world if we demonstrate something beneficial, something which is actually likely to be useful. And having early engagement with regulators has been really important. So we've had conversations with FDA and EMA about how this would work out, partly in terms of its utility in drug development, but also beyond that in terms of something which could be integrated into health systems. And finally, data analytics, and this is work in progress. I am an epidemiologist who's used to dealing with survey data. I've never had data the scale of this, the challenge of this, and the varying temporal resolutions and the scale of data is absolutely enormous. So these are huge challenges, and particularly the issue of data missingness, because participants will drop out of this study and drop back in during the course of the treatment. And that data missingness may often be actually quite informative. It may be the first thing you do as you start getting depressed, is you stop answering the questionnaires which we're posting out. Thank you very much.
Thank you very much, Matthew. And we are coming back to this side of the ocean with Peter. Peter, please go ahead.
Thank you for inviting me to come and present. I'm presenting for the National Network of Depression Centers in our effort to establish a learning health system for mood outcomes, for mood disorders, bipolar disorder and depression. You know, the last 5 years we've been working on building the infrastructure for this learning health system. So we're not quite there at the point where we're starting to analyze data and apply some of the methods that we're seeing here, but we're hopefully getting close to being at that position. And so what I want to provide is a high-level description of the stuff that we've been working on. So really the NNDC is a consortium of around 26 academic centers around the country that provide care for patients with bipolar disorder and depression. The goals of the consortium are to advance care, patient care for these patients, to promote research and to promote education around the mood disorders. And so we've been working on establishing this mood outcomes program, which is our flagship initiative for trying to create this learning health system for mood disorders across the country, across these 26 academic centers. The mood outcomes program, there's really 4 goals for the mood outcomes program. The first really is to implement this idea of a measurement-based care program as standard of care across all our centers. There's a lot of evidence that measurement-based care works and is used for patients, but there's been reluctance to adopt reporting requirements from CMS like MACRA. The third goal of the mood outcomes program really is to facilitate this collaborative multi-site prospective research in these real-world settings across these academic centers. And then the fourth goal really is to be able to take those findings from these efforts to be able to translate them back into improved care for our patients across each of these centers that are participating in the consortium. And so in this way, the idea is that this mood outcomes program can serve as an engine for driving the adoption of this learning health system across each of the centers that are participating in it. So we've been working on this initiative for the past 4 or 5 years to try to develop the infrastructure to support this program and to help us to get to that goal. And we've made considerable progress over those 4 years. You know, the first step was to agree on a standard set of measures, patient-reported outcome measures that we wanted to capture from our patients at every clinic visit, so that it was like capturing vital signs from these patients as they're receiving care in our centers, and that the clinicians would use that information as part of improving care. So we went through a process of working with each of the centers, and we agreed on 3 measures to capture at every visit: the PHQ-9, which we've heard about from other centers, the GAD-7, and the Columbia Suicide Self-Rating Scale. And then we developed an IT infrastructure for patients to complete these measures across each of these centers, and then for the results of those scales to be viewed in real time by the clinicians to really be used for measurement-based care, not only for screening, but for continual tracking of the patients as they're providing care to the patients. So we've gone through a pilot phase where we've implemented this program at 8 centers across the country. We've enrolled 10,000 patients, and we just finished that pilot program, and we're very encouraged by it. And we're now at the step we're going to be trying to disseminate this program to the rest of the 26 centers across the consortium, so that we're disseminating it more widely. We're also have been involved in an initiative working with Epic. Over 2/3 of the centers are Epic, use Epic as their local electronic medical record, so that we can pull other data from the electronic medical record, including encounters, problems, diagnoses, medications, procedures, and lists. Pull that data with the patient-reported outcome measures, pull it into a central repository where we can then use that as a platform for the types of work that we want to do, whether it is quality improvement or these large-scale multi-site research projects where it's analyzing secondary analysis of existing clinical data, or to embed studies in these real-world settings, whether it's a comparative effectiveness study or a pragmatic clinical trial. So we're in the process.
Sorry, this is Guillermo, and I truly apologize to Peter and to Scott that is coming next, but I just got a call from NIH saying that we're like 5 minutes behind. So if I apologize, but if we could cut it minutes from each of you, I apologize.
Sure. So I'll finish real quickly, and sorry for going long. One thing that I think is interesting is we've leveraged this program that we've established just recently to engage in and initiate a large-scale study of ECT across our centers. We're implementing this program in our ECT centers across these academic centers that are participating in the program. We're harmonizing how we're documenting ECT across these programs. And what we're going to be doing is, as our patients are receiving care through ECT, we're going to be collecting biological sample so that we can carry out genetic studies, look for genetic markers of severe treatment-resistant depression and response to ECT, both in terms of efficacy and cognitive side effects. And our hope is that we'll be able to use that knowledge that we gained from that large-scale study, which we're doing in collaboration with the PGC Psychiatric Genomics Consortium, to identify markers of who are good candidates for ECT and who might respond well, that would then feed into these sort of machine learning and AI algorithms that we're talking about. So that's just the beginning of the sorts of projects that we think will be really exciting that we'll be able to build on top of this program. The next slide laid out a couple of challenges, but I think that they've all been sort of talked about in one way or another from other folks. So I think in the interest, Guillermo, of the interest of time, maybe I should stop there and pass it on to the next person.
Thank you very much. And again, I apologize if we could hear and listen to each one of you guys for an entire day, but we have a busy agenda. Scott, you're next. Thank you very much.
Yeah. Can you hear me okay, Guillermo and others?
Yes.
Great. Well, thanks. I think I should be able to keep this brief, and I want to talk about a program of work that is relatively early days, and so I don't have as much in terms of data and results to present. But just to talk about a couple of sort of main problems or questions that we're working on. I'm a clinical psychologist and professor in the Department of Psychiatry at Duke. I'm also the director of the Duke ADHD program, and we have been sort of thinking about this for a couple years, along with myself, along with colleagues, including Guillermo, as well as Jerry Dawson and others here at Duke. One of the things that we've recognized is that that child health and child mental health are sort of relatively understudied, under-addressed in terms of the applications of data science to improving those conditions. And being trained as a child psychologist, this is sort of a nice place for me to start thinking about how to use some of these methods to improve the lives of kids. So we are working on a few things. This is funded in part by support from NIMH as well as NICHD and some internal support. Kind of two basic questions. First of all, can we improve the way that we surveil risk for both ADHD and autism, as well as other more general neurodevelopmental problems using primarily EHR-based risk prediction models and taking information that is available only through the EHR, applying machine learning, natural language processing, and being able to identify kids earlier than they would otherwise be presenting for an assessment or a diagnosis of autism and ADHD. And then the second part of this work is prospective. It's to validate the models that we're able to build and then see if there's additional information that we can gather that would improve or refine the model's performance. And that includes both sophisticated computer vision-based tools that Guillermo and others are working on, as well as the addition of other patient-reported outcomes and surveys and things like that. Part of the platform to do this prospective validation is through an Autism Center of Excellence that Jerry Dawson and myself are PIs of. One of the projects in that center is we are ascertaining all kids that come through Duke Peds primary care starting at 18 months, and we're able to then track them and see who ends up developing both ADHD and autism, and then use additional questions that are part of the study, additional surveys and so forth that are part of the study to see if that improves model performance. If you go to the next slide, please. So we were also asked to talk a little bit about successes and challenges so far. So in terms of our successes to date, and again, this is relatively early days. We've been working on this for about a year to 18 months. We've had both institutional as well as NIH funding to support this work, which we're grateful for. And we've been able to successfully extract and curate a fairly large data set from the Duke Health System, about 30,000 patients, and started to work on the modeling using the EHR. And so to date, we actually have a decent baseline model that we're continually working on to refine. And we've already got a paper under review now. One of our fellows that is significant differences between kids who are later diagnosed with autism or ADHD in terms of their healthcare utilization as measured through the health record. We've had some challenges, this isn't any surprise to this audience. The complexity of the EHR data is profound, and we've spent a lot of time working through that. We know that a lot of the important risk factors that are in the health record are part of the mother's health record and even the father's, and that has been a challenge that we are working through to be able to link those data to refine the model performance. And one of the big ones that we're starting to really think about, and having heard some of the other presenters, it's exciting to hear some of the other sort of precedents in this area, but for us to think about what do we do when we get a good model, and how are we going to then integrate that into primary care? We're just now starting work to understand different stakeholders' input on how they would use or think about risk if it's identified early. So what do you do with a model that says you've got an 80% chance that your 12-month-old will later be diagnosed with autism and ADHD? There's a lot to understand about how primary care pediatricians, as well as patient caregivers, how they're going to be using that information. And so we're really interested to start to understand that better, so then we can start to develop interventions and deploy them through the health record and other places. So I think I'll stop there. Thank you.
Thank you very much. Thanks to all the speakers. And I will pass this to Helen to moderate the discussion. Thank you, everybody.
Helen, you may be muted.
I now am unmuted. Thank you for the reminder. You'd think we do this every day, that we would remember that. But thank you so much for those great discussions. And now we actually have 4 discussants who are going to make some comments on these exciting projects that were presented. One of the things someone said about patient engagement and burden, one thing I haven't heard that I want us to be thinking about is the importance of human-centered design, and not only sort of the content of our tools, but how we present them, and that those are going to impact not only our results, but also our ability to scale our tools to be used in actual practices. So now I'm going to turn to Laura Germain, who's from McLean.
Hear me?
Yes, we can. Yes.
Great. Let me know if I start to fade out. So I absolutely agree. The discussion about patient-centered design and thinking about what the role of the patient is and patient burden, I think a critical piece that we often have as a footnote or a future direction or an end piece in all of the discussions about clinical applications of machine learning and AI. But I think that, one thing that is, I think, a challenge for the field is how do we put that in the middle of the project? How do we think about not just, talking to patients in the form of, patient, which I think is really critical and really important, but, how can we engage patient communities to actually be a part of the process of developing algorithms? So you think about how many really smart data scientists and engineers there are out there who are part of, maybe they're patients themselves, maybe they have family members who are patients. One of the things that's been striking to me about this situation we find ourselves in with COVID-19, the pandemic, is how much people who are not disease experts, have actually contributed to our thinking about prediction about what's going to happen next and what are the right public health interventions. Seeing the collaboration between epidemiologists and everyday people who have good skills in these areas has been really remarkable. So how do we think about engaging patient communities in the process of algorithm development is one point. And the second point that's related is, where does open data fit in here? So we worry about privacy, but what about sharing? Are there conflicts between the incentive structure around IP and around future commercialization, around this incentive structures of science that are really preventing us from having data be shared in a way that would be maximally would advance scientific progress? So those are just, I think, the 2 points that I would like to have us talk a little bit about, or at least bring into the discussion.
Those are fantastic. Thank you. I think we're going to go through each of our discussants to give these short responses and then address questions that are coming through. So Roy from Partners, can you go next, please?
Sure. So I enjoyed all the presentations. It's nice to hear everybody pulled together in one place. So a few years ago, I was presenting some of our natural language processing, RDoc, Hocus Pocus, at Broad, and one of my colleagues leaned forward and said, "So is this a problem of science or engineering?" And I think that's a critical point for us to keep in mind, is that much of what we're talking about is not, it's not that the science isn't there, but it's really a question of engineering, in the sense of, we have, as Greg and others have mentioned, we have models that by objective performance metrics look very good. And so I do think one of the things we have to consider is why has there not been more dissemination? We and others have been doing this kind of thing. I published a machine learning for treatment resistance prediction model 8 years ago. Not replicated, not used. And so I think one of the big challenges that we should be explicit about, that people may not be comfortable acknowledging, is that EPIC is the 800-pound gorilla, and EPIC is a massive barrier to progress and dissemination. So it's wonderful that we all have, many of us have access to this sort of common data model, but it's also a huge challenge when EPIC owns by contract any code that touches theirs. And it's just very hard to build on top of it. I want to mention a few sort of specific things. So the JAMA network had an RFA out for machine learning papers. And so I've probably seen over the last year 100+ psychiatry machine learning clinical application papers. I wanted to just highlight 3 things we need to talk about besides sort of engineering. One of them is, I don't care about your AUC, and I don't care that your AUC is, I can overfit my data too, especially for rare events. And so I think it'd be really helpful for the field if we focus on PPV and NPV and other sort of clinically interpretable parameters, as well as calibration, right? So how well can I stratify risk? I think we need real external validation. What does your model look like in another health system? So our standard has become, cross-validation is great, but how does it do across the country or across town? And that, I think, leads into the final point, which is we have to get past this sort of Groundhog Day approach to machine learning, where everyone presents their model as if there were no prior art. Again, we're now 5 to 8 years into this era when lots of us are building models, and yet it's always the first time. Our model, significantly exceeds chance. And so I think the last point I would make is, first of all, the default should be, if you're presenting a new model, you don't just compare it to chance, you compare it to the one that the folks down the street or across the country built. And I'm still not seeing that for things like suicide prediction. And also we have to compare it to actual clinical practice and sort of what are some metrics. Not just chance, because we hope clinicians do a little bit better than chance, and we need to think a little bit about how we evaluate our models. So those are some challenges for the very smart folks on this call, I think, to consider in how do we get to dissemination.
Roy, thank you so much. Those were excellent and bracing comments that I think really frame the things we've heard and will be hearing. I'm going to turn now to Tanzim Chowdhury from Cornell.
Thank you. So I wanted to kind of make 3 points, and one is around kind of patient-centered or user-centered design. I think we have a broken model of chasing after engagement. We talk about how do we engage patients, how do we engage doctors in a lot of the measurements that we can collect. Just like even if we had a system where a doctor came to our house to deliver treatment, we don't want them to come every day, right? That would drive us insane. We think of engagement as something that the user should check every day or multiple times a day. I think it should be much more geared towards where the need is. When I'm doing well, everything's going well, the system should fade into the background. It should engage and deliver me useful content and actionable content when I need it. I think we are kind of driven by the model of Twitter and Facebook, or that you have to be always on, and which I think is broken and we haven't addressed adequately enough. The other is kind of building up on Roy's points, is that what cross data set insights can we get? I think we have all these results that shows predictive ability, but nothing that tries to bring data sets together. And I think that's something NIH could incentivize quite a bit. That now there are multiple centers that have collected longitudinal. I work a lot on mobile sensing data, but others have worked on online data. That how do we bring them together and make sure they work? And I was kind of interested in the data that Rebecca presented in the suicide risk presentation of what they had developed, and some of the reproducibility in Alaska. I think we need a lot more of that. And the other thing I would say is, if we think about it, I'm a technologist, in the technology realm, we have a lot of measurement, right? Now we can say in the mobile context, we can reliably measure a lot of things without user burden and all sorts of things. And then we have a huge slew of intervention that works on mobile devices or continuously for the patient, but they're not connected, right? Yes, you go and say you need 8 hours to 10,000 steps or whatever, but they should be much more seamlessly integrated. And the measurements are not driving the intervention in a way. For example, the things that we are measuring is not guiding CBT or ICBT, and some of it is not even well aligned, right? So yes, there is measurements of sleep and energy, which could be triggered, but what kind of intervention is well aligned with the measurements? And I don't think we've thought about that enough. We just kind of say we do CBT, but sometimes we should explore it more broadly. That's it.
Fantastic. Thank you, Tanzim. And I think that one of the things I'm hearing in what you said is accounting for human complexity and comorbidity across psychiatric disorders when we're looking at sort of focused on prediction in one area, whether that's taking that into account. So finally, Dr. Morency from CMU.
Yes, thank you very much. Great pleasure to be here. I'm a computer scientist by training, and probably by heart would wish was a psychiatrist or psychologist. I just want to bring on the point that Roy made earlier. We talk a lot about sharing data. We didn't talk as much about sharing what we will call trained model with these parameters, easy to replicate model from machine learning. And I think that's one of the issues that is being raised in machine learning probably 10 plus years ago and has been changing. I don't see it's changing as quickly in healthcare. People don't share not only the data, we see some for the data, but also sharing the model. My heart is in multimodal also, and multimodal is the science of heterogeneous data. This is including also temporal heterogeneity. And so when we think of heterogeneous data, we talk a lot about mobile phone, but I also want to bring up, there's other modalities as well. We have a lot of emphasis these days on telemedicine, and their modalities are the 3V of communication: verbal, vocal, and visual. And I think we want to also think about these modalities And I want to bring, because we discussed like machine learning and deep learning have great advantages. They can often learn from large amount of data, deep neural architectures, but they have big challenges that they bring in compared to typical statistical approaches. Interpretability is a big one. Another one is fairness. And the third one is personalization. So it's much harder in a deep neural architecture to do interpretability of the result. Why is it working? Fairness is hard. Like, is it working because in my population there were more men than women, and suddenly I have a bias? And that was also one of the points that was mentioned in the question. And finally, personalization. We talk about using the same system in many different hospitals. We need to be able to quickly and efficiently personalize it and customize it. And I will just end with the idea, which is not completely new, but has not been emphasized yet, so I want to bring it. The paradigm, we talk about human knowledge, we talk about machine learning, but we didn't talk as much about these hybrid human and machine learning, where the learning happens together and that there is a mix and a collaboration. So these are new, interesting paradigms, and at least new up to now in the discussion, not new because I brought it, but just I want to bring it in the discussion. Thank you.
Thank you so much. That's fantastic. And I would add to your comment around personalization that it's not only the issue of personalization for different systems or health systems, it's how you translate prediction done on the group level to prediction of individual trajectories and individual pathways. So it's reflected there. I know we have some questions. One of the questions
I'm sorry, Helen, I just want to break in to do a time check. We're going to have about 5 minutes before we go on break.
Right.
And we have Susan Azrin from NIMH, who's been monitoring our chat box and Q&A box and has queued up some questions to lead off the discussion.
Great.
Susan, you want to go ahead?
Yes, thank you. Can you hear me?
Yes.
Great, thanks. So this question is from Holly Campbell-Rosen to any of the panelists who'd like to jump in. Could one imagine a tool where providers and patients get guidance and then in nearly real time interact with a predictive system in the clinic, creating a closed loop that incorporates adverse effects, treatment preferences, and the like, and which may adjust the decisions?
Yeah, I mean, this is Greg Simon. What I'd say is yes. I mean, you know, that's what we would hope to build in terms of guiding depression treatment. And I think we will get there. But as I said, there's some key things we need to develop in terms of the kind of better data we need. You know, as I'm fond of saying, we talk a lot about omics, genomics, metabolomics, proteomics, but we need to think more about preference omics and value omics in terms of how we incorporate what people want and how they feel into decision making. I think the technical challenge there is not that difficult. We just need to prioritize it.
Great.
I would just add to that, this is Peter, that to get to that vision, I think Roy's comments are pretty prescient here. That will require equal parts science and equal parts engineering to develop that kind of solution, to be able to develop those predictive models and to develop the engineering to deliver those in a way that's useful to both the clinician and the provider. So I think Roy's comments in this regard are really on target.
This is Rebecca. I'll add that one way we found around that is to develop web-based decision support tools that to the user look like they're part of Epic and they're integrated with Epic. So the things that the clinicians do in Epic inform the risk tools, and that creates that loop. But because it's web-based, it's not change it more quickly as guidelines change or other information changes.
We call it the sidecar approach, and that's been our strategy as well. I think that the difficulty is you got to remember most of psychiatry is primary care, right? And so while we as psychiatrists might sit around and look at the tool and think about this and a little bit of that, most of the PCPs I talk to say, just tell me what to prescribe. And make it easy. Let me click a button. And that kind of integration with with Epic, I think, is where the engineering piece comes. We got to make it so we present a recommendation, they press a button. That doesn't mean they shouldn't have the conversation, but in the real world, it rarely happens. So we have to acknowledge that.
Holly, do we have time for one more question, or should we?
Yeah, Susan, I think we have time for one more question.
Great. This is from Daniel Handworker. It's for Greg and Rebecca, the MHRN. The question is, the MHRN data collection seems to focus on patients with risk of suicide and self-harm, and this points to a general issue. Are there data collection biases in these systems for patient populations that don't engage with the healthcare systems as regularly?
Yeah, this Greg, I'd say, the data that are theoretically available to us include the entire data exhaustive healthcare from every healthcare encounter received now, probably 25 million people. We typically will create purpose-built data sets for a particular job. So the job of suicide risk prediction, we harvest data specific to suicide risk prediction for people who are at elevated risk. But the native data are comprehensive. All that said, they reflect healthcare. And as we know, especially regarding mental health problems, there are people who never seek care and their conditions may go completely unrecognized. And those people may differentially come from traditionally underserved racial and ethnic minority groups, for instance. So yes, there are biases in the data available to us reflecting the biases in access to health care in this country.
Thank you. Helen and Guillermo, any concluding remarks?
Guillermo, you want to go speak first?
Let me just thank everybody, and just maybe for the future discussion. I know there were some questions about interpretability, and that Greg had some great comments. I'm sure it will come back. I just want to put that sometimes it's not about interpretability, but it's about transparency. And that's something that we also need to put forward. And I want to thank the panel. I want to thank the opportunity that NIH gave us, and wish everybody stay safe and continue learning this afternoon.
Yes, and I echo that, and thank you so much. And I know already there have been things I've learned and questions raised that I hadn't thought about. So thank you to each of our presenters and to our discussants.
Great. Well, thank you, Helen. Thank you, Guillermo. That concludes our first two morning sessions. We're now going to take a 15-minute break. We will resume right on time at 11:30 a.m. Eastern Standard Time. And please take this as an opportunity to stretch and get some food and coffee and fuel up, because we have even more exciting discussions to come. And those of you who did not have your questions answered, we will circle back to those during our 1-hour general discussion session between 1:30 and 2:30 p.m. Eastern Time. So we're going on break now, and we'll resume at 11:30 a.m. Eastern Time. Thank you so much. In about 3 minutes. We're going to be resuming. I just want to do an audio check for our next two moderators, Jen Goldsack and Jeff Gerard. Test your audio.
Hi, Holly, this is Jen.
And do we have Jeff Gerard?
Yeah, how does this sound?
Perfect. So welcome back. Again, I'm Holly Lisenby from the National Institute of Mental Health, and welcome back to the second half of our virtual workshop on transforming the practice of mental health care. I want to thank the participants from the morning sessions who really helped set the stage for where we would like to go in terms of our future vision for providing personalized and effective care for every person, wherever they're receiving treatment. and laying out the lessons learned from efforts currently underway to mobilize large data sets, multimodal data to inform care. Now, session 3 is where the rubber hits the road. We're going to devote this session to learning, to discussing how do we get from where we are now to that desired future state. I'd like to thank our moderators, Jen Golsak, who is leads the strategy portfolio and operations at Health Mode and serves as the interim executive director of the Digital Medicine Society, or DIME, who's joined as co-moderator by Jeff Girard, who completed his postdoctoral research associate at Carnegie Mellon University and is now assistant professor and Wright faculty scholar at University of Kansas. I'd like to, without further ado, hand it over to Jen Golsak to kick us off.
Thank you so much. And Jeff, I think you're going to do the run-in for us today, right?
Yeah, so we'll off a little bit here. So in this third session, we will be discussing the intimidating but also thrilling task of trying to turn these technological promises and possibilities into realities that are both scientifically grounded and clinically feasible. And walking this path forward is going to present many challenges that we have to overcome. Some of them are unique to specific subareas like genetics or different areas that each of us work in, and then other ones are probably going to be common across many different areas. And so we're hoping to explore all of that. And I'm excited to have a really fantastic panel here today who really represents a wide swath of areas from academia, medicine, industry, and government. To discuss their thoughts and especially their kind of in-person experiences in kind of trying to blaze these trails forward. So each speaker is going to make a brief presentation. We're hoping around 3 minutes, maybe a couple of minutes longer, but we'll try to keep you short. And then we'll have a broader discussion where, again, we're looking for those unique as well as more common themes that emerge from this. So with that in mind, we'll start things off with Glenn Coppersmith, who is the founder and CEO of Quantify, and we'll be speaking about quantifying mental health signals from digital life.
And Glenn, you may be muted. Okay, I believe that Glenn may have lost his audio connection. Glenn, can you hear us? And I might make a suggestion.
In that case, why don't we skip ahead? Brian, why don't you dive in with your presentation, and then as Glenn jumps back in, we will revisit his presentation. So thank you for advancing the slides, guys. I really appreciate it. So Brian, if you want to briefly introduce yourself and then dive straight into your presentation on intermediate biomarkers.
Sure. Can you hear me?
Perfectly. Thanks, Brian.
Great. Yeah, so my name is Brian Pepin. I'm an entrepreneur working in the sort of software and data analytics around neuroscience therapeutics, specifically neuromodulation, TMS, DBS, SCS type therapeutics. I'm going to talk about I'm going to kind of talk through this quick example to just demonstrate a concept that I think is important for the panel, which is that if you're talking about developing therapeutics, maybe especially neuromodulation therapy, so pharma therapeutics, behavior for psychiatric conditions or other kind of brain disorders, from depression to autism and sort of everything in between, behavioral endpoints are really tough to use because they're noisy. They can vary from rater to rater. There's all kinds of other factors that go into play. I think everybody's sort of familiar that why those things are difficult. And so what we're seeing is a movement towards using a variety of metrics, ranging from sort of imaging, EEG, fMRI type metrics, all the way down to sort of digital health actigraphy type metrics, to augment, I think, initially, and then ultimately replace these behavioral biomarkers as endpoints, or replace behavioral endpoints with these new kind of more quantitative biomarker defined endpoints. So this example is for Duchenne muscular dystrophy, where it's a neurodegenerative disorder children, and the conventional endpoint for this is something called a 6-minute walking test, which has a lot of behavioral elements to it. The patient basically walks back and forth over this 6-meter course over 6 minutes, and then you record how many times they sort of walk back and forth. So there is even though there's an element of quantification here, a lot of behavioral elements that get sort of bleed in. So it's stereotyped, heavily stereotyped. Patient motivation is known to play a very major factor. There's all the normal stuff around the patient has to, come into the clinic, and patients have movement disorders that can be difficult. And then, as people mentioned in the last session, you get the snapshot effect too for a condition which realistically is fluctuating over time. As you can advance to the next slide. So what some of our colleagues at Genentech Roche have done in this case is taken that 6-minute walking test endpoint and replaced it with what they call a 95% stride velocity endpoint. So they use a wearable watch-like device that's actually the children wear on their ankles, and they just wear the sort of normal course of daily life, and they're sort of and basically they wear around as they would normally, essentially, and wearable detects when they're walking, and it measures this metric which is called 95% stride velocity. So it's not the peak stride velocity, but it's just off, and there's various reasons why they're doing that, but the end result is what you have is a continuous, so you're measuring a bigger picture of the patient's whole experience. You're quantifying it more accurately without these confounding things of like motivation and having to travel into the clinic. And what they found is that the effect size for these two tests is somewhat similar, 7% versus 8.5%, but the standard deviation for the stride velocity test is far lower, so 7.9% versus 20%. And what that translates to in terms of therapeutic development is an N of 14 and a study time of 6 months for the stride velocity endpoint versus an N of 112 and a study time of 12 months for the 6-minute walking test endpoint. And so they've actually gone and started the approval process for this new endpoint in Europe. And I think they're awaiting some final decisions, and then they're also working through the FDA to get this. So they've actually taken even the next step of saying, okay, we have this sort of or intermediate quantitative biomarker. We're actually going to go and get this. We feel like we have enough evidence to go get this approved as the primary endpoint for a study. And then once it's approved for the primary endpoint, in this case, this is a somewhat rare disease, so it makes it much easier for them to recruit for clinical trials because it can be a smaller trial and it can happen faster. And so it can increase the speed at which they can iterate on drug development and make it more cost efficient. So that's real money there in terms of those clinical trial numbers. So that's kind of the example I wanted to go over, and then there's many different examples of this for how these kind of markers can make a difference in autism drug development or depression drug development. But this one was just a really nice kind of quantified example. So wanted to share it.
Fantastic. Thank you so much, Brian. And Glenn, do we have you back on the line?
Maybe. Everybody hearing me?
Yes, I heard that.
All right. I'm sorry about that.
No problem. I'll let Jeff introduce you as these slides come up. And just a note for everyone on the line, we'll run through all of our presentations. We'll then have a short discussion, and then we'll take questions. So if you have questions for our presenters as they go, please feel free to enter those into the chat box. And with that, Jeff, I'll give it back to you. And thanks again, Brian.
Yeah, thank you for being flexible here. So Glenn, why don't you introduce yourself briefly and then go through your presentation on quantifying mental health signals from digital life.
Thanks for that, and I apologize for the audio issues. It's always the tech guy that has the issues, right? So I'm Glenn Coppersmith. I'm a founder and CEO of Quantify. And we're a tiny company that couldn't afford the vowels when we got started. But I've lived in this world in between computer science and psych my whole career. And so this is sort of the outpouring of that. Next slide, please. So what I wanted to briefly touch on here is that what we're facing is a wicked problem in the Riddle and Weber sense, right? This is not a binary decision as to what medication we should give someone. This is not a binary decision about what treatment we should give them, but it's actually more like trying to drive an autonomous car. We're not going to pick a point on the map and take a picture of the trajectory from here to there and use that as the sole source of navigation. This is actually much more like the continual feedback loops that we want. So as things are changing in the world, not that there's been any major changes in the world recently. I mean, things are pretty steady as far as I understand it. But as things are changing in everyday life, and as people's personalization, their desire, what they need out of a treatment is going to change. And so one of the fundamental flaws in all of the applications of AI and machine learning in this space is that we actually need to think about this in terms of the continual measures. And so how do we actually get from here to there instead of the binary distinction? And so this is the way you solve wicked problems, are small compounding iterative improvements in measuring constantly. And that constant measurement is the piece that's missing. Next slide, please. And so there is some work here. We've done some work in the past looking at those lines are about estimating suicide risk from data from outside the healthcare system. And so it's wonderful to see a couple people had a version of this plot where looking at the healthcare system interactions and other non-healthcare system data is present there, right? So if all we're talking about is using EHR data, we're in some ways limited to looking at what happens within that healthcare interaction. And so this is one person over the course of 3 years, and you'll see up top in red their healthcare system interactions, in blue their posts on social media, and in gray their wearables or Fitbits. And so what we've been looking at, and we do see there's a bunch of literature, not just the stuff that Quantify's published, on looking at these things. There are great measures here, and what we really need to be able to do is to get the humans to trust these measures. And so this is the largest challenge that I've run into over the last 7 years that I've been doing this, is that convincing the clinicians that this is a reasonable at, and there is useful information here, to fill in that white space, has been the sort of fundamental challenge. So from my perspective, the tech is solved or solvable. The really hard part is the interaction with the humans. So with that, I'll step back. Thank you very much.
Oh, that's great. Yeah, thank you for staying on time and for your thoughts on that. I really like that metaphor of the autonomous vehicle and this being a continual process. I think next we will have John Torres, who's the director of the Digital Psychiatry Division at Beth Israel Deaconess Medical Center. And he'll be talking about mental health app uptake and clinical integration.
Great, so thank you guys. So I'll jump right in, maybe fast, go to the next slide. I think that there's a lot of interest from our patients and clinicians in using mental health apps to kind of augment and extend care. What's tricky though is I think the metrics we have today about uptake and use are not accurate. On the left, you kind of see a paper from 2016 that showed that star ratings and number of downloads really means nothing about health app and quality. On the right, you see a very interesting paper in 2019 looking at people in the public who download a mental health app, how many people are actually still using it 2 weeks later? The answer is about 4%. The one app group that bucks the trend is peer support in gray. Those apps had about 18% engagement. So again, I think we have to be honest about who we're reaching. It's not just that it's on the App Store, that's good. It's kind of what is happening and how do we pick it. We'll go next slide. So I think as Glenn just told us, there really are some issues around trusting these things. This is again an article screenshot I took from March 9th, 2020 that says this mental health app threatened to sue security researchers over a bug report. So I think we do kind of still have some security issues in this that are kind of holding back trust. On the right is a paper we published in NPJ Digital Medicine where we actually read app stores and looked at what is the evidence that these apps are claiming in their descriptions. It was about 64% or 44% were using scientific language about their app. We tracked that evidence down. It really was about 1.4%. So again, there's a lot of reasons for kind of people to be a little bit skeptical. Next slide. So we've done some work with the American Psychiatric Association, not recommending any app, not endorsing any app, but kind of giving people evidence-based principles and guidelines, a framework to ask questions about, to think about making a smart choice in these apps. And you can see it really starts with privacy and security, and then clinical foundation, which is evidence, and then thinking about engagement, and then kind of think about therapeutic goal. Recently, New York City, actually, before this pandemic, kind of used this framework to make their own app library. So we're not saying which apps you should pick. We're saying, look, just ask the right questions, make smart decisions. All the things we've heard this morning, let's put this evidence to use in frameworks that people can use to kind of use the right apps and have good experiences. We'll go next slide. So our team actually does a lot of work on digital phenotyping. That's actually our main thing of predicting relapse and psychosis with smartphone sensors. And that research is very exciting. In part, we can actually use elements of that today in what we call a digital clinic. So you can see kind of on that 1, 2, 3, 4, 5, those are different digital data streams that we can collect in research, but also from our patients. Some on step count. 2 is passive data showing what call and text logs could look like. We don't know what people are saying or the content, but you can see we can kind of see what days were people kind of more socially active on calls and text. We can have people tag their environment, number 3. We can have people take real-time surveys, number 4. We can begin to do kind of simple inference and predicting, does your anxiety today tell us about, say, your mood tomorrow? But what we do actually to kind of take this outside of research, which again, we're doing, but as well to put it into clinical uses, we work with a patient in our clinic and we say, you know, what is the clinical question? What data would be useful for us to learn about? And you can kind of see on that flat icons diagram, we can say, hey, are we trying to learn about anxiety and sleep? Let's track those for next visit and add a survey. Are we trying to learn about mood and mobility patterns? Let's track that. So for each patient, we can kind of customize what we can do, what we can collect. So we'll go next slide. So this slide isn't meant to overwhelm people. In the app platform we use, that's open source. We have no commercial venture. We offer people ways to do learn, as talked about, manage, prevent, and it's overwhelming. There's a lot of different options you can use. And for each patient, we don't want to use all the things. We want to customize what people can do. And I think that's where the clinical integration really comes in. Not everyone needs every sensor, needs kind of everything we can do. We can pick the right ones for the right people. So we'll go next slide. In part, again, this is kind of a schematic of how we kind of run a digital clinic. On the left, we still put the patient and clinician together. Supporting a therapeutic bond is the most important. And a technology part kind of is an addition. We've actually created a new team member that we call a digital navigator. Just like in radiology, you have a radiology tech and pathology of pathology tech. It's probably time for mental health to have our version of kind of a technologist, and we call it digital navigator, really because there's a lot of patient interaction, there's a lot of supporting the therapeutic alliance. Kind of in that schematic on the right, you can kind of see different things that we do in our clinic that the digital navigator supports in this role. And I'll go one last slide. We also think it's important to be teaching our patients with serious mental illness how to use technology. Again, we do a lot of work in early psychosis and schizophrenia and bipolar disorder, and patients may increasingly have phones. They've been given them, their social worker gave them a phone. They don't really think of their phone as a tool that can promote their recovery. And so hosting groups that kind of teach people how to use their smartphones as meaningful tools in health and give them the skills and competencies really can be a very powerful intervention just on its own. So we have this manual up called DOORS, Digital Outcomes in Recovery Services. It's open source, it's free, you can look at it. We're always looking for people kind of helping us do that as well. So with that, I think I am out of slides. Thank you.
John, that was terrific. Thank you so much. So next we'll hear from Akane Sano, who's going to talk to us about sort of the barriers and challenges as we try and move towards data-driven mental health care. Akane, if you could introduce yourself to our guests and then dive right in. Thanks so much.
Hello, everyone. My name is Akane Sano. I'm an assistant professor at Rice University. I'm an engineer and computer scientist working on developing machine learning, personalized machine learning model, especially for mental health and sleep, and using multimodal physiological and behavioral data. So yeah, since this morning we have a lot of discussion about data, then I just want to briefly talk about the challenges as engineer and computer scientist to deal with this kind of data set for mental health research. And we have various kind of different data set from different sources and clinical data, some digital data, smartphone, computer usage, sensors, internet services. We also have self-report. And we have various kind of challenges. For example, is it better to collect more data? What is the burden of users and the investigators who are running to collect data. And we have a lot of noise, especially the data we are working on is coming from their daily life setting. So we have some missing data and noises, and how can we deal with those data? And as we already discussed, the user and patient adherence is another issue. And also physiologically, behaviorally, the patient user status has been changing all the time. So we have to think about how can we deal with like time varying status. We also have a lot of individual differences, and so some data, so the labels, clinical labels or self-reported data includes very skewed information. That means the distribution might not be, Gaussian, just normal Gaussian. We have a lot of skewed data around high scores, low scores. And also, if we think about, for example, detecting relapses, predicting relapses, suicidal events, those events are very rare. And compared to non-rare event, it's very hard to detect and catch those rare events. Next, please. So if we think about machine learning models and data science approaches for mental health care, there are a lot of ongoing research. For example, we want to classify or we want to diagnose mental health disorders. We also want to detect or predict patient symptoms, risks, or even not for patient, but also we are interested in how we can how we can detect people who might have a high risk in mental health disorders. Not only detection, prediction, diagnosis, classification, but also we are also interested in selecting treatment intervention to right users at the right timing. And a lot of ongoing research has been tried to develop machine learning models. And also recently, one of the things we have discussed in the previous session is personalization. So personalization is the one of the key element, especially because everyone is very different and our situations, context, trait, physiology is changing all the time. Then not only personalization, but also we have to think about how to think about like subtypes of a group of people, because everyone is different, but it's difficult to get a lot of data from each individual. So if we think about like subtyping people into subgroups, and then we might be able to develop better models. And another challenge is dynamics. As I already mentioned, people's physiology, behavior, preference, conditions has been changing. So our machine learning model has to be also dynamic. However, a lot of models we have developed so far has been still very static. Next, please. So if we think about what's the ideal data we can collect and we can use for our research or treatment, and the data has to be, of course, like long term, and we really want to have a data from diverse populations of patients and users in terms of demographics, geographic regions, and again, some of the clinical events can be very rare. So we want to have more data about those clinical rare events. And since many of us are interested in integrating like multimodal data source, so this data format has to be like, consistent and standardized. So this data will definitely help understanding individual and subtype differences. Also, we also need to think about how to build some environment of like building and testing like dynamic and personalized machine learning models to capture time varying user symptoms and physiology and behavior. Next, please. But then another thing we have to think about is So a lot of us, like data machine learning researchers, has been developing a lot of models. But how much precision, like reliability and interpretability do we really need in building clinically useful and trustful tools? So this is not about accuracy, precision, but also what kind of outcomes should we provide through this kind of models? What kind of tools, informations are really useful for clinicians, patients, and other stakeholders? And deep learning has been very successful even in healthcare setting. However, a lot of people know that we sacrifice some interpretability in deep learning. So how can we take between interpretability versus precision? And also another thing I want to emphasize here is we really need to build some research environment to integrate, compare different data sets from multiple studies, multiple sites, and also some research environment to accelerate developing and testing the effectiveness and safety of machine learning models and our findings. And some of the healthcare research, for example, ICU data, like MIMIC database and the PhysioNet, physiological data set, has been public, and this has been successful to increase the number of research activity. So in like mental health research, I'm really hoping to the kind of things will be happening, and Institute of Mental Health will be accelerating the kind of activities. Thank you.
Okay, so now I think we will move on to Matt Switzler and James Hickman, who are both coming from Epic. And we're excited to be able to kind of hear from them directly about working on the electronic medical record.
All right, can you guys hear me?
Yes.
Yep. Hello? All right. Hi, everybody. My name is Matt Switzler. I'm a software developer on the behavioral health team here at Epic. Epic, we provide electronic medical records, as well as lots of other systems that health systems can use to help their operations. Lots of the other presenters have talked about the types of data that you can get out of them. Kind of in the traditional model of clinical decision support, this was typically implemented by a human that needs to have robust research behind it to have the appropriate interventions. And we've seen lots of good outcomes for these systems in data-rich environments, but one of the fundamental struggles that we've been hitting in the mental health space is that unlike when patients have physical medicine problems, conditions deteriorate, for physical medicine conditions, those they tend to engage more with the healthcare system. We can collect more data points about them. Whereas if somebody has a mental health problem, they tend to engage less with the healthcare system as well as many other parts of their life, which gives us less data to work with. So even if you are sending out things like questionnaires and that sort of thing, there's no promise that you can get that back. That being said, even with some of these limitations, when we've been able to see some pretty good outcomes in areas like reducing no-show rates, determining readmission risk, as well as the early detection of physical medicine diseases. For example, we've done a lot of cool work around sepsis. So the infrastructure is in place and it's making a difference kind of today. And we have active work ongoing to help augment that with AI and machine learning. And we're glad that we can be at a forum like this to improve this in the behavioral health space. I'm going to pass it over to James, and we'll want to advance the next slide. And he's going to talk about what we're doing to augment these systems with AI in Epic.
Thanks, Matt. So as Matt mentioned, our focus, our experience at Epic is really with the application of machine learning at the point of care, and that includes the acute care setting, of course, the ambulatory clinic, and then increasingly outside of the health system walls for population health. The early wide efforts, industry being machine learning within healthcare, have focused on helping and improving workflows that already took advantage of scoring tools with more accurate machine learning predictions. But I think in the last couple of years, we do see a little bit of a feedback loop emerging as health systems are starting to look at leveraging machine learning for their informaticists to enable new workflows. And some recent examples of that are centralized monitoring in the hospital setting, and also a large number of specialty-specific predictions that are putting more power in the hands of a primary care provider or other frontline providers prior to the consult and to the more limited specialty resources, be that nephrology or perhaps behavioral health. There are some key concepts that we found are important to ensure the success of these efforts, lots echoed already this morning. The first is providing tools that are transparent. And of course, that's important from a quality and an ethical standpoint, but it's also key to success for increasing the actionability, if you will, of these tools. So in our experience, this has been a little bit less of a concern over the kind of arms race of the type of algorithm that we're choosing. And it's much more around user-centered design and exactly how we present that prediction to a particular user. The second is putting the prediction in clinical workflow. So catching that patient when we have them with us for a visit, perhaps also taking advantage of brand new clinical documentation and rapidly revising a patient's risk for a particular event in real time. And then last, I certainly agree that we must put a premium on the experience of providers that we're asking to use these tools. So there's really an emerging science in designing both UI and models that aren't solely optimizing towards accuracy, but really the impact in clinical workflow. And to that end, certainly I'll support some of the statements made earlier about the difference between something like area under the curve as a method of evaluating models, and particularly emphasizing some of the threshold metrics like positive predictive value or negative predictive value. So our development at Epic and the opportunities that we have to work with health systems that are clients of Epic has really focused on making the deployment as technically easy as possible and while maintaining intellectual property rights. We certainly welcome conversation today or afterwards about the role that Matt and I and others at Epic as developers can play in motivating and supporting the spread and sharing of models. We understand that there's data challenges. We understand that there are also intellectual property questions and sort of validation on different populations and things like that. Happy to participate in all of those. So really appreciate the opportunity to listen in and participate with so many leaders in this space. Thank you.
Matt, James, thank you so much for joining us today. And let's move on to our final presentation of this session before we dive into our discussion. We welcome Donnell Johnson to talk a little bit about the importance of the workforce keeping pace with this era of technology. Donnell, if you'd like to introduce yourself and then dive in, that would be great. Thanks so much.
Sure, thank you. I'm Commander Donnell Johnson. I work in the National Mental Health and Substance Use Policy Laboratory at SAMHSA. And so I'm just going to talk to you about some of the challenges and opportunities with workforce as far as transforming the practice of mental health care. You can go to the next slide, please. Okay, so given SAMHSA's charge to reduce the impact of mental illness and substance misuse on America's communities, ensuring that individuals with mental health have access to evidence-based, high-quality care is a critical focus for us. A major factor in achieving this goal is addressing the training and education needs of our practitioners. To facilitate the achievement of this goal, data on the current numbers and trends within practitioners is imperative. So we have the Mental and Substance Use Disorder Practitioner Data Program, which provides comprehensive data and analysis on individuals who comprise the prevention and treatment fields to address mental and substance use disorders. So the goal of the program is to provide a valid data on existing practitioners and usable information to SAMHSA on which to make policy and planning decisions. For instance, knowing how many and the variation of practitioners can help us determine the needs and areas to focus on. For instance, we know traditionally minorities are underrepresented in this in behavioral health practitioners. So we have the Minority Fellowship Program, which supports the development of behavioral health practitioners. Specifically, it aims to increase the presence, knowledge, and skills available to serve racial and ethnic minority populations. By increasing the number of culturally competent professionals in the workforce, the program seeks to reduce health disparities and improve behavioral health care outcomes for underserved minority communities. The program also seeks to encourage racial and ethnic minorities to join the behavioral health workforce. The relative scarcity of professionals who are from culturally and linguistically diverse backgrounds constitutes a workforce issue that contributes to the current disparities in quality of care and access to behavioral health treatment. We also have the technology transfer centers, and so These centers help to develop and strengthen the specialized behavioral health care and primary health care workforce that provides prevention, treatment, and recovery support services for substance use and mental health disorders. The mission is to help people and organizations to incorporate effective evidence-based practices into substance use disorder and mental health prevention, treatment, and recovery services. Together, the network serves all 50 states, the District of Columbia, Puerto Rico, the U.S. Virgin Islands, Guam, American Samoa, Palau, Marshall Islands, Micronesia, and the Marinara Islands. Now, through the centers, we provide technical assistance to all providers, not just SAMHSA grantees. So within these centers and the training programs that I mentioned, there are opportunities to educate and train providers on using technology, which can address some of the barriers. For instance, it can help to increase providers' knowledge and comfort with using the technology, as well as them being able to gain an understanding of their patients' knowledge and comfort in using that technology. Also, help them to acquire the knowledge about privacy and reimbursement policies around the use of technology, especially with things like telemedicine and all the rules around how you can get reimbursed for that. While there may be barriers such as cost and infrastructure to using technology, both on the provider end as well as the patient end, training and educating the workforce to effectively use technology in practice is an opportunity for improving access to care. So that's about it, but I just think we can't forget the importance of helping the workforce to get on board with this so that they can move it forward. So thank you.
Terrific, Donnell, thank you so much. And just to orient folks on the line for how we're going to handle the rest of the session, Jeff and I will leave some quick fire questions for our panelists, and then we'll throw it open for those of you on the line to pose questions directly to our experts. And I'll kick us off, Jeff, if I can, and dive in. Glenn, question directly for you. During the prep work, we had some discussion about sort of what the limiting factors are for introducing these sort of digital measures into this sort of practice of mental health care. You and I were on the same page that we don't believe sort of technology is the limiting factor. I wonder if you could talk to us about what you believe some of the other considerations are beyond the technology itself. What's holding up the implementation of these digital tools?
Yeah, thank you for that. I agree. I think that the technology is a solved in the grand scheme of things here, and the larger barriers are cultural ones and they're ethical ones. And so I may not say what you're going to expect me to say, in that the patients want more analysis in different things. They see what they're getting for targeted advertisement and that works stupidly well. And then they turn around and none of that data is being, or little of that data or is being used to help them, it captures a lot of the same data, but it's not being used to help them understand their well-being and helping to make them better. And so this has, I think this all comes down to a single point that we can look at, and it's a very interesting ethical discussion I've had with a number of clinical colleagues, in that this is a very interesting spot where we're putting privacy against the duty of care. And so if we have technology that's capable, for example, of predicting suicide risk from all the public data that we can find about a person, or even more interestingly, people that have opted into it, if we could predict the suicide risk that's going to outstrip the capabilities within the healthcare system, this is now putting the privacy of the patient, who they've given it away. They're willing for us to do analysis of them. They're willing to be analyzed, putting that up against the duty of care for a system that is, there is a real cost for not engaging with these sorts of things. And so so often it's a one-sided thing, right? The privacy of the patient is paramount, and I agree. But there's also this other side of that coin, where there is a cost in terms of lives, if we're not going to use some of the technology available to us. And so that all comes down to this, that is the point of this, like, large ethical, everyone screams that there's ethical issues here, and there might be, but at the same time, like, we have to look at both sides of this ethical issue, not just that the technology is somehow scary.
Glenn, that was terrific, and a really sort of provocative teaser, I think, for our next session on ethics. So strong work on the segue there. Thank you, Glenn. Akane, I wonder if we could pose the next question to you. You spoke a lot about having the right data in order to do this well. What else do we need to build sort of clinically useful and trustworthy tools in mental health?
Hi. I think, yeah, in addition to the data, we need definitely, some system, some ideally like online system for researchers to test, like build and test our models like in real time. And also, the important thing is, we also need to communicate closely with clinicians and users and what they are looking for and what kind of user experience they have. So I'm an engineer and computer scientist, but I also closely work with clinicians. We also need to integrate this, like working with various stakeholders and getting input into our system and like, models.
Fantastic. Thank you, Akane. Jeff, you've got a couple of questions for our colleagues, I think.
I do, yeah. So I'll aim the next one at Brian. So we had talked about quite a bit in the whole workshop today about this idea that these new technological measures could help us actually inform more tailored therapeutic regimens. So I'm hoping you can speak a little bit to how does the rubber actually meet the road on that? How do we integrate these measures into tailoring the therapies that we actually provide?
Hey, thanks, Jeff. So kind of I'll go two elements here. So one is you have to have the right end goal in mind. And by that, I mean, ultimately you're trying to get an FDA approved therapy with this sort of intermediate biomarker as maybe a companion diagnostic, or you're getting an FDA approved biomarker linking some physiological output to some behavioral trait or some clinical diagnosis. So, oh, excuse me. So that implies a lot of sharing of your data with the FDA, building broad scientific consensus. These things generally aren't patentable. Just the link between a physical signal and a sort of physical outcome aren't typically patentable. So you have to kind of have that framework in mind. That if you're a company, this biomarker is not going to be your competitive advantage, right? You can't kind of have it both ways and have a biomarker that's your competitive advantage, and also something that there's broad scientific consensus in the community such that it can get FDA approval and actually be used as an endpoint. Those are sort of mutually not compatible. Kind of similar if you're an academic group, you can't, I think, have a very big impact if you're just sort of, creating sort of data sets which you don't consent in a way that they can ever leave your in a de-identified way, even ever leave your university servers, and then your group can continue to publish off those papers, but it's very hard to replicate, very hard to integrate that with other work that people are doing, and you never build this broad consensus that this is a real biomarker. So I think starting from that philosophical place, which is, I think there's still a lot of people that are all across the map there, is a good beginning, and then practically. To get these things actually integrated in the studies, basically just realize they don't come for free. Like the infrastructure to do this, the patient software interfaces, the platforms, the actual hardware devices, none of that is free. And so if you're a biotech or a pharma company or a med tech company, and people are doing this, you just have to budget for that, and think, okay, if I have this and I can run a clinical study in 6 months instead of 12 months and with 14 patients instead of 50 patients, how much is that saving me? How much what's the uncertainty there? How much can I budget for this? Maybe budgeting ahead even, and integrating that, and finding the right partners. And there's for every indication across psychiatric disorders and everything else, there are companies that partner with pharma and biotech to do these sorts of things. On the academic side, I think there's some stuff the NIH can do in terms of properly incentivizing people to do things like have open source or access layers for at least the de-identified data, so that data sets from different groups are a little bit more interoperable. kind of proactively, well, when they're thinking about funding studies, making sure that there's plans for this kind of layer of quantitative biomarker stuff to be done with they're using common platforms, and that the data infrastructure is there so that that data can kind of live beyond the study and not just be sort of aggregated in, or not but just kind of dumped into a bunch of file folders and posted in the NDA. So I think
That's great, Brian. Thank you. Yeah, so really trying to find ways to align kind of the incentive structures that exist for both companies and researchers with what we need to move the field forward. I think it's a really critical point I'm glad you raised. For the sake of time, sorry to cut you off. I think I'm going to move on to the next question for John. It was great to have somebody who's really on the front lines trying to do this stuff as a clinician. And so I was hoping John could speak a little bit to what is the actual experience like, both for providers, but also critically for patients, to actually try to use these types of digital tools. What are the good and troublesome aspects of that in your perspective?
I think that's a good phrasing. There's good aspects and there's troubling. I think that sometimes there's frustration because there'll be very interesting scientific papers, reports done about using these technologies. But when you kind of read the research, you go, well, that was done in a way that really doesn't match how we're going to deploy it in clinical settings. Or again, if you pay everyone $100, they get an extra therapist, they get a yacht and a jet and a mental health app, and they feel better. That doesn't kind of always answer the question. So kind of having studies that may be rigorous, but again, and because they're rigorous, we know as you kind of add active controls, these app interventions, that they're not going to look as strong. But I think having evidence that's kind of realistic and applicable and generalizable is so important because people do want to pick this up. Clinicians want to offer the best services for tools. Patients want to get the best outcomes. So I think we're all on the same page, but I think sometimes there's a little bit of the hopes kind of get ahead of the evidence. That said, I think also designing these things to think about how to fit into a clinical workflow. In part, we did kind of design our digital clinic at Beth Israel to redo the workflow to kind of make sure we could use apps and technology. But I think it's something we don't love to think about kind of messy implementation details. But I think even very simple algorithms and sensors can go a long way when they're kind of thought about that implementation, and those results can actually be generalizable that our clinician colleagues, again, myself included, when we're doing this, can learn from.
That's great, thank you. Jen, do we have one more kind of specific question before we go to the broad ones?
Yes, so for Danelle, and John, thank you, that was really terrific. I liked how you spoke about the evidence needing to sort of keep pace with expectations. Danelle, your workforce presentation was really excellent, and I wonder if you could go into a little bit more detail about how a more representative workforce can help better integrate sort of behavioral health into broader public health, sort of traditional clinical care, and research, and also how can we think about the role of technology in facilitating that process?
Okay, sure, thanks. So a more representative workforce can be used to inform public health, traditional healthcare, and research. These providers are able to bring real-world experiences into all those fields. And a representative workforce is not just necessarily limited to demographics, but also specializations in the different workforces. So, for example, I forgot which presenter it was earlier that mentioned the need for more child mental health specialties. So again, they can help to inform that and address these areas that need more specialists and areas like that. So it can definitely inform the areas that you mentioned. As far as technology goes, technology can absolutely help to better connect individuals and providers, keeping in mind we do need to address some of the barriers. But with the advent of the mobile technologies, healthcare services can now be provided in new ways. Look at it now, like, with the COVID-19 going on, we're using a lot of technology. Providers are using it. Some of them may not have been informed or comfortable using it, but being forced to do it now. So I think with the representative workforce, if they're knowledgeable about technology, they can gauge their patient's comfort and they can know what to utilize. Maybe everyone, especially the older population, may not use smartphones, but it could just be a simple telephone call that the providers would be able to use. So they need to be aware and trained on the technology.
And I'll just add quickly, I think peer specialists, it's a really great opportunity to kind of have them help in this kind of technology implementation role. We have a new need, we have peer specialists who really can do some amazing work in this space.
Yeah, that's a very interesting resource to kind of broaden that workforce even further. I had forgotten we have one more question. We haven't talked a specific question for Matt and James. We had basically talked about both in this session and in previous ones about sort of a need for some standardization in terms of data and just the myriad challenges that come from working with data on the large scale, especially when it's unstructured. And so something like Epic and the electronic health record systems possibly presents a nice streamlined way of obtaining that type of standardization. So I'm hoping you can talk a bit about what you guys at Epic are doing, or what you personally see as being important steps on the path forward to that standardization.
Yeah, I think there's a couple different ways we approach this at Epic. I think probably the broad one is we do participate in groups like Care Quality, HL7, we follow the FHIR standard, and we're often commenting on any ONC proposed rules around interoperability, so that even, you might be inside an Epic system, but if you travel to a Cerner hospital, we want to make sure that we can exchange data with those groups. And we don't focus solely on medical information. We continue to push them on behavioral data, psychological data, as well as social factors to make sure that they're considering that. From an implementation perspective, we in general push all of our implementations to track data discreetly. Kind of a rule of thumb we use is if you're not going to get the data back out, don't bother putting it in. So we try to think about some of those reporting components at the very onset before people are even in the system. Those are kind of the big things I'm thinking about. James, do you have anything to add to that?
Yeah, a couple of things. Kind of thinking a little bit about comments earlier from Greg and Roy. We have an opportunity to work with a lot of health systems that are maybe deploying their own models, or perhaps at times taking advantage of a model trained elsewhere. And our approach has been to guide those organizations to document things as uniformly as possible. Overarching goal is absolutely to reduce the technical overhead of sharing and spreading models. We would absolutely love to see further uptake of shared ontologies like Loink for Labs, for example, but in the interim, working pretty closely with health systems to make sure that as they're managing and transforming data, be it in a data warehouse or some other system, that they are taking approaches that reduce the overhead of sharing the model. Our kind of strategy has been overall to make that validation and the understanding of how a model travels as easy as possible, because there's plenty of complexity on the operational side of evaluating how that model best fits into clinical workflows. Thanks.
Matt, James, that's terrific. We are very spoiled, I think. Our hosts have been curating questions from the audience. Let's break now and see what questions folks on the line might have for this session's experts.
So we have Jenny Pachenko from NIMH. Jenny, do you have some questions for the group?
Hi, yeah, I have one that's more of a comment, but for anyone else that's on the line, if you have some questions, you can use the chat box or the Q&A section to post any questions. But the comment I have was just following up on Akane's point about the need for resources to train and test models. They're saying that there's an interesting example outside of the clinical domain for training deep RL models in the gym by OpenAI. They provide a structured way to interface with data and test models and compare models across different environments. So the suggestion here is that there might be the potential to use a similar concept to protect patient privacy, but still provide an interface to researchers who want to build new models. I'm not sure if any of our presenters would have a comment or anything to respond to that.
There are some ongoing efforts. I think NORC has one, and University of Maryland at least are working on these things that are like data enclaves, and this is a slightly different take on that. But how do you bring the researcher, vet the researcher, and bring the researcher to the data, rather than bring the data to the researcher? And so there's a lot of good paradigms there, and I'm happy to chat with anyone who has interest in that particular thing.
I'll also say, if as we're waiting for other questions to come in, we have a few other ones too that we had prepared just in case. So one I think kind of common theme that emerged was this idea of trust and buy-in, both from the providers and the patients. And I think one of the things we had talked about was maybe trying to do a better job of aligning the types of metrics that doctors know and expect with maybe what is more common in the machine learning and predictive spaces. But what else do we need to do to make sure that trust and buy-in are optimized here, and that we're really being responsive and kind of proactive about this? And so this is a question for anybody who wants to chime in.
I'll be quick here. The users will tell you. This is at least in the app world, right? If you look at retention over time, so John had that great slide about how quickly people are falling off. Right, 2 weeks later, they're not using most of these apps. That's a good indicator that that's not going to work over the long term to induce behavioral change. And so, I mean, we have Our Data Helps, which is an opt-in study. We've had 6,000 users that have been willing to be part of that for 4 years. And so part of that is we're listening to the lived experience community, and we're engaging with them, not a focus group, but like continually looking at retention rates. And so like we should take a page from the app world. They've done this really well because they're heavily incentivized to do it.
This is John. I think the trust issue is very important, because again, about trust, you don't have health or mental health. But again, I think the bar that we're asking for trust is that if people give data about their mental health, it's used for their mental health. It's not going to be shared, traded, bartered. This is not an extremely high bar. We can go higher, but I think that if you kind of look at, unfortunately, if you kind of go to what consumers are using today, what patients and doctors are using today, it's such kind of an abysmal setting for kind of trust and privacy that I think even small efforts, again, we don't have to fix all of it, would kind of offer exponential increases in trust, which would lead to better engagement, to better data quality and outcomes. So I think this is something we could fix today.
And John, if I can riff off that just for a quick second as perhaps a last question for our session, how important are things like sort of health and tech literacy in getting that right and getting that sort of communication and transparency, which is so crucial to trust, making sure that it's sort of equitable across the board?
In kind of running our digital health training groups for patients with psychosis, we've been actually very impressed at how quickly people can learn to use smartphones, and they get excited about it. But a lot of times, if no one has actually sat down and said, did you know that your phone is probably tracking steps automatically? Or did you know here's how you can refill medications automatically? These are things that people's phones can do. They're actually very excited, and then they kind of want to build new skills and competencies. But I think as we kind of move more digitally first, as we're talking about here, making sure people aren't digitally excluded because they don't have, again, the skills and competencies and confidence is probably of utmost importance. And again, it's not as fancy as kind of some other things, but I think it's kind of the real work that we have to do to make sure that we help everyone.
Fantastic. So it looks like we're nearly at time. I want to say thank you to Jeff for being a brilliant co-moderator for this session. Also to Glenn, to Akani, to Brian, John, Danelle, Matt, and James for being absolutely terrific sort of discussants for this session. As we think about the sort of the barriers and the challenges and the opportunities, what's clear to me after this conversation is that it's too simple to sort of point the finger at, it's the tech that's the challenge, or it's the sort of the human users and implementers that are holding things up. It's really clear that there are issues really at the interface of the technology and of all of the humans involved. And really what shone through is the need to build trust using evidence, and to do all of that built with sort of the end user, whether that's the clinician, whether that's the patient, or whether it's the person charged with sort of implementing this technology, keeping them front of mind as we build that trust and evidence. So again, thank you so much to all of our experts. This was terrific. I learned a great deal. Thank you for everyone for hanging on the line for another great session. And I'll turn it back to our NIMH, I think I got that right, hosts.
Yes, thank you very much, Jen and Jeff, for a stimulating session, which is a very nice segue into our last session prior to our discussion, which will be on ethics, privacy, and special populations, specifically child adolescent as well as geriatric patients as well. So I'd like to thank our co-moderators for this session, Dr. Dilip Jesti, who is a Senior Associate Dean for Healthy Aging and Senior Care and Distinguished Professor of Psychiatry and the Levi Memorial Chair in Aging, and Director of the Stein Institute for Research on Aging at UCSD. I'd also like to thank Dr. Jeremy Veenstra van der Wiel, who is the Rowan Professor for the Implementation of Science for Child and Adolescent Mental Health at Columbia and the Director of the Division of Child and Adolescent Psychiatry. And together they are going to lead us through our discussion with these really outstanding panelists. So let me hand it over to Dilip.
Thank you. Good afternoon, although it is still morning in California. Thank you, Holly, for inviting me to join this really important workshop. So this last session on ethics, privacy, and spatial populations is especially important in the field of mental health. AI faces some special challenges in the field of psychiatry. One is that most of our outcome measures are subjective, unlike, say, radiology or oncology. Secondly, most of our patients and their families don't have access to state-of-the-art technology. And last but not least, our consumers are often vulnerable to being taken advantage of or even being abused by others. So these issues of both privacy and security as well as ethics become critical. And I'm just delighted that we have a terrific panel of experts in various related areas, and we'll be hearing from them. Let me turn over to my co-moderator, Jeremy.
Sure. Thank you, Dilip. And I should say it's it's been a really exciting workshop thus far. It feels like there's been a thread of ethical discussion running through from the very beginning. We are going to do our best to, at least for the first half, stay out of the way of our eminent group of panelists. Really a terrific group. We're going to provide only quite brief introductions and let them speak for themselves. And then in the second half, we will do our best to ask at least somewhat provocative questions before opening things up for a general discussion. Dilip, I think you'll introduce the first few.
Yes. So I'm delighted to start with my colleague, Camille Nebeker, who is Associate Professor of Family Medicine, Public Health, and Psychiatry at University of California, San Diego. He's also Director of Recode Health, our Research Center for Optimal Digital Ethics. Camille?
Thank you, Dilip. Thanks so much. And it's a pleasure. I wanted to start off, first of all, just to do a brief primer on what we mean when we talk about ethical, legal, and social implications. And I've just done this quickly so that we can be grounded in at least how I'm thinking about ethical dimensions of research and clinical practice, and especially with respect to digital tools that are being used in mental health as well as general population health. So under the ethical domain, we think primarily of the Belmont principles of beneficence, respect, and justice. And is the consent accessible? Do the people that we're asking to participate in studies or to use a certain type of clinical intervention, do they have the health technology, data technology, literacy to be able to use whatever we're asking them to use. Oftentimes, the technologies can pick up signals from people that are nearby the participant or the patient. So we also need to think more about what are the bystander rights with respect to using digital tools in health. Beneficence, the principle of beneficence is really about looking at the risks in relation to benefits. How do we identify these risks, quantify those risks, and then balance those in relation to potential benefits that could come to not only the individual but to society at large. And justice is really about who is sharing the burden of any type of research that we are pushing out, and are they like the people that are most in need of what's developed, what knowledge is developed. And so access is a real critical part of that. When we move into the regulatory domain, the focus is really on the law, which is not an area of specialization for me, but the federal regulations for research have been updated. Do those updates really map to the types of activities that are happening in the digital health spectrum? We look at conflict of interest, the new privacy rules like GDPR and the California CCPR regulation, and then social impact. We have to think about what is the downstream effect of the things that we're deploying now. How have we engaged our communities in helping to determine whether or not the things that we're planning to do are right for them? And then this newer area of returning information, returning value to people that are participating in our study is becoming an area that is really important to unpack. Next slide, please. So if we think about the characteristics, these are also challenges of digital research. As we all know, we're very connected, the smart environment, we're using these tools more frequently in research. We can monitor and intervene with people 24/7 in real time. We can capture just amounts of granular data. We cannot promise data anonymity anymore. We cannot even really be confident that de-identification is going to work. And so, you know, the other thing that's happened in the past 6-7 years is that these tools have enabled access to people who are now doing studies on themselves. So a growing area of citizen science is happening. We also have, you know, our technology industries involved in biomedical research, as well as nonprofits. So whereas we have regulations and research for those of us in academic environments, those of us that accept federal funding, those regulations do not map to everyone who is involved in this ecosystem. And so we have unregulated, regulated, untrained, trained, and people in this sector that are very thoughtful about ethical dimensions and some that have no idea what they should be thinking about. And so this is a really important area to be thoughtful of at the very front end of anything that's being developed, to make sure that we don't experience those downstream effects. Next slide, please. And so in collaboration with Dr. John Torres and Rebecca Ellis, we have developed a framework that is created through an iterative research process with ethical principles at the core. And what this is looking at is helping people who are developing technology, choosing technologies to use in research, for clinicians that are trying to make a decision about what tool might be useful for their patients, but to think through the privacy implications, access and usability, data management, and risks and benefits. And so what we've done is we've created, using this as our framework, a checklist that helps people to think through, what do I need to think about before making a decision to use a certain product? And so I can talk more about that offline and share this checklist and framework with those of you that are interested. And I'll pass it back to Dr. Jesty. Thank you.
Thank you, Camille. Our next speaker is Dr. Ken Duckworth, who is Medical Director of NIMH, the National Alliance on Mental Illness, the largest national grassroots organization in mental health. Ken?
Hello, Dilip, and hello, everybody. I've learned a lot so far, and Dilip, I remember fondly your presentation at the NAMI convention some years back. We love our researchers. I just want to let you know NAMI's had quite a couple of weeks. We're experiencing record calls at the helpline, and the state and local affiliates are being, I would say, overwhelmed with questions about mental health and COVID-19. One thing I want to offer from a few points of perspective is when I talk to people at NAMI, and I do listen to them a lot, one of the problems we face as a group of individuals trying to make things better is they have at times felt oversold by second-generation antipsychotics that don't have side effects, for example, or for antidepressants that don't cause dry mouth. Each has been revealed to demonstrate different and profound problems for the population. So one of the things, I'm interested in thinking about is how to frame this for people that it doesn't become another set of what people would say are disappointments after they've been told that new treatments are better, materially better. And I acknowledge that some new treatments are better for some people, but I just want you to know that's kind of part of the framework of people. They're observing that they're taking the same medications or the mechanisms of actions as their family members might have 2 decades ago. And access to hospitals is hard, access to prisons is easy. So this is we have a loving and wonderful community, but a lot of people feel disaffected from the overall outcome of the fragmented, chaotic, patchwork mental health system. And so how do you do co-creation with people with big experience? I heard several people talk about this idea, giving people feedback. How do you help people self-manage? Ultimately, the idea that symptoms are useful for their own recovery journey. How do you do co-creation so that the people who are the end users of the process experience this as something that is collaborative and ultimately for them? I do want to mention on a different note that NAMI did a project with Google putting up the PHQ-9 on mobile phones. And while I'm not at liberty to discuss the numbers of people who took the PHQ-9 on mobile phones, the number is enormous. And I feel like that's an example of technology that didn't require a lot of complexity. And we had large numbers of people come to the NAMI webpage as a result. In the British Medical Journal, I was invited to do a debate with a gentleman from England who had a much better accent than I did, who was against this entire democratization of screening tools. And so it's just interesting to me, his concerns were largely about privacy. This is Simon Delight, and privacy and the lack of interpretation of these tools. At NAMI, we would trust people, you have to empower people. They're already living with their symptoms, and we feel like blood pressure, people should know their PHQ-9 score. To give one very simple example of how you can get technology out. So until we have kind of uniform application of things like PHQ-9 in people's lexicon, like blood pressure 120/80, I think we are still going to face an uphill battle. I was impressed by the critiques on privacy and the lack of trust of big data and institutions to guard individuals. Google has made it really clear that they had no access to anybody's information of any kind when they listed the PHQ-9. So that was just an interesting small experiment that we did. A lot of people took that, and that didn't require a tremendous amount of collaborative co-creation because it's a tool that already existed. So I'll stop there, and thank you all for all that you're doing, and I appreciate what I'm learning today.
Thank you, Ken. The next speaker is a colleague of Jeremy. Randy Orbach is Associate Professor of Psychiatry at Columbia. He is also Director of Translational Research on Affective Disorders and Suicide Lab at Columbia. Randy?
Thank you for having me. So in full disclosure, I'm not an ethicist by training, but I think deeply about these issues as it relates to trying to translate what we're doing in the lab to try to understand how we could actually detect it in real time. And perhaps most notably, since my lab focuses on depression and suicide, we're really trying to figure out what and when. So what are the things that actually, excuse me, are important to look at? And most notably, like when do these things occur? And oh, sorry, could you advance? And so, in addition to using kind of multimodal neuroimaging, we've also used passive sensor data collection through smartphones. And as many of the speakers have explained in prior presentations, this passive sensor technology, particularly as it relates to adolescents, provides untold access to what is going on in the context of adolescents' everyday life. And you could use a number of different sensors to kind of target very, very specific questions. And what we've done in our lab is really trying to characterize it as well as possible, whether it be phenotypically or neurally, and then trying to see if we could then kind of detect it and take it and translate it outside of the lab. And what's so promising about this in the context of adolescent samples, if you could advance the slide, um, yeah, is that what you could do is then it's not just kind of real-time assessment of these potential behaviors that may map onto depression or suicidal behaviors, but what it affords you is these just-in-time interventions. And what I'm meaning by this, and what's been noted kind of more colloquial throughout, is not necessarily intervening as in treatment, but intervening as an interceding when individuals may actually need services. So perhaps the most punctate case is in the context of suicidal behaviors, whereby you're able to intervene as somebody navigates into a risk state. In the context of depression, it may be interceding earlier in their disease course or earlier in the context of relapse when interventions may be more successful. So it's really within this context, in the context of adolescent populations, that I've been thinking deeply about how to really protect our participants in ongoing studies throughout the lab. Next slide, please. So there are a wide range of issues at play here. The first being is kind of the access to private data. And so when parents and teens come into the lab, we actually explain in kind of painstaking detail as to kind of what we're collecting. And this what kind of circumnavigates the pictures that they're taking on their phone, the websites that they're trafficking, the words that they're writing in their phone, the locations and places that they're going to be. And we've worked with our IRB to kind of figure out the appropriate language. Remember, you have to kind of boil this down into a vernacular that is both kind of palatable to both adult populations, but also adolescent populations, particularly adult populations where English may not be their native tongue. And so what we've kind of done to ensure that there is kind of accessibility of this information is that we include a rudimentary quiz. Are they aware of the types of information that we're collecting, how long we're collecting, and things of that nature? What you also see in terms of looking at adolescents and adults, particularly parents, is that there's this disconnect in privacy. Generally speaking, adolescents are much more liberal in the type of information that they may be inclined to give away, and parents tend to be more conservative. But it's also the case that actually parents aren't aware that they're currently giving a lot of this information away in terms of what they're doing on their phones and what apps they may or may not have downloaded and things of that nature. And so it often begets just a broader conversation of privacy. And I think a point that was touched on by Camille much earlier is that, can we guarantee privacy? And the answer is kind of categorically no. We can do our best. We apply cutting edge encryption standards. We're updating those, typically, month by month as things improve. But for our purposes, we just try to acknowledge the limits of what we can and can't do. Something that has been touched upon, I think, briefly in probably each of the sections today, is our inability in certain cases to do real-time data analysis. Now, there are certainly studies that are able to do this, but when our prediction problem actually isn't solved, so So for example, Dr. Ryan did these AUC findings of 0.92, but if we don't necessarily know the variables of interest going in, but we have a thought of what might be of interest going in, we really can't analyze. And as I think some of the more the engineers in today's presentation noted, it's actually fitting these data actually is extremely complex. And so we both have a kind of a what are the variables of most interest, and then the how in terms of analyzing these data is extremely complex. And so what we've done is we've really tried to just be forthright with the participant populations, meaning that we view this as kind of a three-step phase, at least 3 steps. The first being is that we're trying to identify high-value targets across our different features within passive sensor data. Once we have identified some promising markers, we then seek to test these markers. And then as a third phase, trying to validate it, which is not totally different than a lot of the RCTs that came before us. And then I think the last point from an ethical perspective, and I guess this is not meant to be an exhaustive list, but something that is kind of active in the context of things that we do in the day-to-day, is that there are these unanticipated real-time findings. And an example that we could draw on from my own data is that we do a lot of natural language processing. And when you're doing natural language processing, depending on the technique that you're employing, you find very interesting things when you analyze the words that people type in their phones. So you identify things around unwanted sexual contact, molestation, sexual assault, and things of that nature. And particularly as it relates to teenagers, you don't necessarily always have the commensurate amount of information to necessarily file reports. And I think that we're grappling to try to figure out what is the best way to handle these types of data in terms of protecting our patient population, protecting from perpetration of things like unwanted sexual contact. And again, what I encourage, and this is not to punt this, is that we consider these kind of active ongoing consultations with our own IRB to make sure that we're handling these issues in the most judicious and safe way as possible. Thank you.
Great. Thank you, Randy. These are difficult things to wrestle with. It's my pleasure to introduce Paresh Patel, who is an associate professor at the University of Michigan. We heard earlier from Peter Zandi about the National Network of Depression Centers, and Paresh is going to share with us some of the data use and management issues that have arisen regarding ethical issues within the mood outcomes program of the NNDC. Take it away, Paresh.
Thank you, Jeremy, and thank you to Holly and NIMH for their foresight in organizing this workshop. As Peter introduced in session 2, the NNDC has a clinical and a research mission. One component of the latter is to develop a large and rich registry of mood outcomes data in order to develop better treatment strategies for mood disorders. It's achieving this by cooperation among the 26 and growing academic centers and non-academic mental health treatment programs. We've already heard some ethical considerations raised by other presenters and discussions this morning, and here I just want to highlight some of them that are relevant to the NNDC data set, and they're highlighted on the slide. Now, it goes without saying that we're working with sensitive personal data, and the pains are taken to maintain the privacy and the abstraction and storage of that data. The NNDC research data is considered secondary because it's derived from a primary data set developed for providing just-in-time clinical decision support to clinicians. But it really challenges the ethical principle of respect and transparency because patients are not explicitly told about the de-identified abstraction and are not aware, other than in the sort of boilerplate language that most institutions have for general consent for treatment, that de-identified findings of their records will become part of a national registry. We can talk about this some more in the discussion, but this is an issue for all the professional society registries, many of which also collect PHI. One of the biggest challenges to privacy is really sort of an embarrassment of our success, which is increasingly sophisticated analytic platforms that can potentially re-identify patients through the linking of separate data sets. Likely some of the more fruitful discoveries will come from a combination of data sets, but this is a privacy risk that's difficult to anticipate and arguably not universally considered by IRBs as they try to negotiate this complex and rapidly evolving landscape. Another ethical consideration with federated data is data integrity and accuracy. This is a principle that GDPR pushes. People are mobile, and so federated clinical data may contain disparate fragments of the same individual's data, and the identified data set that's very challenging. In our fragmented national healthcare system, that's even particularly challenging because we don't have universal patient identifiers. So harmonizing that data is really difficult and arguably almost impossible in de-identified data sets, but it introduces a lot of noise. The ethical principle of justice is always challenging. There's obviously the ethical imperative to be attentive to patients whose data we're leveraging. But most academic centers have developed data stewardship committees that hold as one principle the intellectual property in their clinical population. This was brought up earlier, and it raises the question that as clinical margins to support research continue to shrink, what barriers might this intellectual property focus raise? Currently, in our experience, it hasn't been huge, but it does come up. A significant ethical concern with research on de-identified data is beneficence for actionable findings. De-identification makes some research data sets possible, such as the NIMH research registry. It also creates a barrier to feedback for actionable findings. And has been mentioned before, research populations often suffer from underrepresentation of disadvantaged populations. Our data collection reflects the underlying population, but it is biased by representation at our major academic centers. And finally, I want to kind of raise a provocative quandary, which is not listed here, but it's highlighted by the COVID epidemic. All of us in the clinical space are witness to what unprecedented relaxing of the privacy rules in order to address the acute threat that by the latest estimates could take upwards of 100,000 lives in the US. And yet these regulations present challenges to the kind of data we need to address the scourge of, for example, suicide that has been taking up to 50,000 lives annually for many years. I'm not advocating that we abrogate research-related patient protection rules, but we really need to think about developing technologies and policies to balance the ethics of protecting patients and the ethical imperative, if you will, of quickly arriving at some more effective treatments, especially when it involves large-scale, multi-site federated data. Next slide. So here I just tried to think about some potential solutions, and these are not necessarily, not necessarily novel, and things that people already probably doing, like masking, coding sensitive information. Something that we as a country have not really come to grips with is a universal patient identifier, but it would really potentially significantly help towards integrity and accuracy in federated data. We need better mechanisms to recontact patients with de-identified data sets for transparency and opt-out options and actionable findings, something like an honest broker system, which some institutions do deploy, but in the NNDC data set, that would be very challenging. There's some data management strategies that people are developing, some sophisticated algorithms for trying to manage PHI risk in distributed networks, but the idea that we need ways to make sure that integrated data doesn't accidentally re-identify subjects. As I mentioned, we need to promote models to balance the patient's justice and institutional rewards, maybe increase incentives and decrease barriers for data sharing while maintaining safeguards for the security and patient confidentiality. And finally, figuring incentives to balance the challenges of recruiting underrepresented and disadvantaged populations. Thank you.
Great, thank you, Paresh. And thank you for keeping right to time. I'm conscious that we want to make sure that we do keep our next speakers to the 4 minutes each. It is my pleasure to introduce Luke Chang, Assistant Professor at Dartmouth, and Director of the Computational Social Affective Neuroscience Laboratory, grappling with these questions in real time.
Thanks. It's been an absolute pleasure to hear from all these different perspectives about the issues, the promise and also the issues of working this, and also across different types of systems, from private companies to healthcare networks, and also from researchers. So I think Camille had outlined a really nice ethical framework on how we should think about the different ethical principles for protecting privacy, but then also for maximizing benefit to our research participants. But I want to basically push on making a case for secondary data analysis. So these are basically when you might work on a data set that for a different question that was originally developed for, and what you had consent from participants from, and for what the funding might have been for. And there's a lot of benefits for this, and this has been, there's a lot of conversations about this over the last few years, but so I just want to highlight some of the highlights. So one of them is that by doing this, you enable new research questions that weren't thought of in the beginning, and then you can go back to old data sets and then try to compare them or generate new things. And that there's a lot of promise in that. It also allows us to enhance scientific reproducibility and minimizing false positives by basically increasing our power and sensitivity to detecting effects that might be there. And also, I think it's been mentioned by multiple people throughout the day, it facilitates development of new research methods. And I think it might have been, I can't remember exactly who mentioned it this morning, but someone mentioned some like ImageNet and some of these data sets that have been publicly available and for computer scientists to develop new models. And a lot of the innovations that have been a result of like having better computational methods, but also having much better data. And so I think that's really important. And it's not always, those people are not always doing that work, are not always on the teams of who might not have access to the data. It also reduces the cost of doing science if we can pool it. And then another kind of underappreciated thing I think is it protects these really valuable scientific resources that are generated from these data sets and enormous money that's poured into it. So if a hard drive fails or a database gets corrupted or a researcher isn't around anymore to share it, having redundant copies stored around the world, I think is really important. Next slide. So these are like the benefits of why we want to do secondary data analysis, but I think it raises even more ethical issues. So first, there's clear issues of privacy, and especially with HIPAA restricting anything that's identifiable. So this could be face information if you're trying to detect like emotions or signatures from voice about how someone's feeling that might put them at more greater risk for self-harm. These are, you can't really share these openly easily. GPS location, for example, is another one where, and device identification. So if you want to use like RFID IDs, radio frequency IDs, to see like how many people are these people coming into contact with, like this type of stuff is impossible to be shared, even though it's being collected by all of these passive sensing studies. Another thing is respect for persons. So people give informed consent for the primary analysis, but there's all these questions that might come up, and in theory, they should be able to choose if they want their data to be used for these other things. But that's not always possible. They might not be able to be contacted. And also the people doing the secondary analyses might not be in touch with the ability to contact them. And there's been some legal cases about this that's raised a bunch of issues as well. And then on the other side, participants are spending all their time to participate in this, and we want to make sure that everything they do, they get the most benefit from, even if it wasn't things that were initially intended from the original study. And then also, I think there's also, it can speak to justice, where increasing the generalizability of our research findings and being able to train models that are much more robust and generalizable will make it accessible, hopefully, to many more populations who might not have been initially involved in some of the original data collection efforts. Okay, so other issues that I think are ethical, but also just really open questions, especially as data sets are kind of being collected across healthcare networks and private companies and also research institutes with federal funding. So who owns the data? Is it the participants themselves? Is it the researchers who collected the data, the research institutes or corporations, funding agencies who might have done it, or even the journals where it gets published? Like these are things that are being grappled in many different fields. Sharing data is really important, but it's also incredibly costly. So it's time consuming. The amount of storage, especially when you start scaling up, is really large, and the bandwidth to transfer data sets across people. There's some data sets in the neuroimaging community, which I'm more a part of, where you actually have to mail hard drives because it's too big to be able to send over online. And also, I think an underappreciated thing is there's these, even you might get funding to collect data for a certain amount of time, but there's indefinite time horizons of what these responsibilities are on the people who've collected data to share. So this might persist for like decades, potentially, if you have a really interesting data set. And that kind of ties into data stewardship. So often, researchers are doing it, they have many different hats on that they're doing, and being an administrator to sharing the data is a very arduous task, and verifying that they have HIPAA compliance and all these other things. So that's expensive. There's also might be legal expertise in negotiating license agreements and intellectual property and things like that. This has led to some universities charging handling fees of upwards of thousands of dollars just to like handle these types of things. Also, this could go on forever, depending if you collected the data. And also, who should shoulder those responsibilities? Should it be the people who collected the data? Should it be the participants themselves, or funding? And then the last thing I want to say is when you scale up the data sharing, there's lots of difficulties that emerge. And one of them that's been touched on, but I don't think it has been explicitly stated throughout the day, is the idea of data standardization. So we can have all these data sets and maybe you can just download them, but if you don't know how to aggregate them or what any of these variables are or who matches to who, that can be really onerous. Thanks.
Thank you, Luke. And I'm privileged to introduce our last speaker, who really has real-time experience managing profound amounts of data. Acting Director of the Division of Scientific Programs for All of Us, the All of Us Research Program. Holly Garriak has her training in genetics and pharmacogenetics, which is one domain where we've actually seen these sorts of database decision-making tools make it into the clinical sphere for better or worse.
Thank you, Jeremy. Let me do a quick check. Can you hear me okay?
Yep, sound great.
Yeah, great. All right, so I'm also not a card-carrying ethicist, but I do have our social legal implications, our LC specialist and lead for the program, Shubha, on the call as well. So if anything, any deep dive questions come in, I will call on her to help back me up. So I hope here to be in line largely with a lot of the framework that Camille put forward in the first presentation. And I think what I'll be saying also addresses a lot of the points that Paresh made as well. So hopefully this will be a nice flow of presentations from framework down to how we're actually doing it in this large national program. So hopefully, clearly my slides got a little confused here, but hopefully everyone knows the All of Us Research Program is a large program aiming to enroll 1 million or more participants in the United States that are willing to donate their electronic health records, self-report survey questions, a fair amount of blood and urine, and a physical measurements assessment, as well as other mobile tech information over a longitudinal period of time. This slide, what I'm showing you here is how we try to balance a lot of our ethical legal tensions that we have as we are implementing the program and partnering with our participants. The first one here is the appropriate reach. So we have a large focus on diversity, and this goes beyond the kind of standard race, ethnicity definition of diversity. We have about 9 indices of diversity that we use to account for underrepresented, historically underrepresented in biomedical research. And so we want to make sure that we're not going too far, but we are going into the right places, both geographically as well as legally. So enrolling the participants that we are able to enroll by law and groups that we're including and purposefully not including at this point in time for ethical reasons. And then demographically, as you know, I'm sure the ages for consent vary by state. And so we're making sure that we are 18 and up in most states and 19 and up in some of the states where we have to be specific there. This is a national implementation of the program, and so we're not able to bring participants into our office the way that Randy described and really sit down with them or their parents to talk about informed consent. So this is an electronic consent for all of the participants that enroll. We need to make sure that the consent is at the correct reading level. We aim for 5th grade reading level or lower. And we need to make sure that they are engaging digitally in an appropriate way and that our program really facilitates that. So we've done a lot of work with Sage Bionetworks to try to make sure that happens. We include some formative assessments to try to promote understanding of the consent as they're going through it. We also have video support as well as on-site clinic support for those participants that need it. For inclusivity, we are really trying to build trust in protecting our participants and our data. We'll largely do this through community engagement and ambassadors across the country. For maximizing benefit here, really want to focus on our concept around having data broadly available from community scientists up to the individuals on this call, the academic ivory towers, and making sure that everybody has access to the data. We're building the infrastructure and hoping everyone will come into the data. We do this using a cloud-based platform for broad access to try to get around all of the data sets and hard drives being passed across the country. So all the researchers come to the cloud, analyze the data, use all the tools and everything there that's possible. In order to minimize harm, we do a lot of data transformation to try to prevent re-identification of the data. We have a couple tiers of access for data. We have a lot of policies and governance groups around access to the data, access to the biospecimens, and access to the participants. And we have a lot of other policies that are in place to try to avoid stigmatization of data as well. A lot more to say. I'm realizing I'm at my 4 minutes. I'm happy to leave the rest for questions. My next slide was around privacy, so it kind of shows the governance that we have in place at the program around privacy and security. And then the following slide is just around return of information to participants, which is one of our core values, and we really see as a return of value to participants. Sorry, Jeremy, went over.
Thank you, Holly. No, appreciate you tracking your own time and holding to it. It's very helpful. I think recognizing the time, Dilip and I are going to go back and forth with some fairly rapid fire questions, but open them up to the overall group to chime in. And then we'll also monitor questions in the background. Dilip, you want to ask the first question?
Thank you, Jeremy. Again, thank you all speakers, great talks. So one theme, it seemed, was common to several of the presentations was giving feedback to the patients about the research information we have collected. And it's not as simple a question as it may appear, because we are collecting information that is of research value, but does it have clinical value? And it may even go in the opposite direction, in the sense we may be interfering with the clinical management of the patient being done by somebody else. So I just want to open this up for different speakers. What is your recommendation about giving feedback of the research information to the study participants?
This is Randy. I mean, it's an excellent question, and it's something that we grapple with. And briefly, I think it really depends on the clinical population with which you're working. You know, in our own data, there's a real negative to have false positives for a suicide attempt, in so much as, you know, although yes, ostensibly you will keep this person safe, but no, this person will likely not continue to participate in your work or clinically continue to use this tool. And I think that Dr. Toros and several others intimated about kind of technology is great, uptake is easy, but not incredibly easy, but dismissal of these tools when they're not working effectively is rapid. And I think that we need time, depending on the clinical question, to develop the right tools to address the right question.
I'd like to build on that, Randy. I think that this is such an important area. Return of information is not a traditional mindset of academics. And when it's clinically actionable, that's one area that you know, in my years as an IRB member, we've struggled with. We've come up with protocols. How do you return information in a way that is responsible, that engages the clinician, that doesn't insert upset? And we're working with Dr. Justy on a longitudinal study with older adults. Everyone is over 65 years of age, and it's a 5-year study where we're collecting physical data, mental health data, cognitive data, and also they're using wearable sensors. And so we're getting so much information about them. And what we did is we wanted to know, what is it you want back? How do you want to be engaged in this study for 5 years? And this gets at short-term and long-term engagement. And so when we spoke to them and we conducted focus groups, we actually work closely with the people that are in the study, as you do. And what we were saying to them is that, you know, we have this information, and what we're trying to do is predict whether or not you have a higher likelihood of falling down 6 months from now, or that your, you know, cognitive abilities are declining. They said to us, we want to know what you're learning, and we want to know not only how we compare with people that are like us, but how I compare to myself over time. And Philip said some of this is clinically relevant and some of it is research data. So what we did before we started to think about how do we return individual level data, we are looking at how do we return group level information. So we took the publications that we put in peer-reviewed literature, and we broke that information down, and we, you know, similar to what you'd see in a press release. And we shared that with them, and they said, that's not quite good enough. We don't understand some of these words. We don't know how that related to us. And then we took that information and synthesized it even more and created infographics. And we took it back to the community, and we said, well, what do you think about presenting information at a group level this way? got more feedback about words, about layout, about colors. And now we're on our third iteration. And I think engaging the community is critical for learning what we need to give back. And it's basically tailoring it to them. Some want to know about actionable. Some people don't want to know if it's not actionable. And so we really have to be thoughtful. I think, when I was working with the All of Us research program, it was returning assay information. Well, what if you find out that you live in an environment that is, you're exposed to lead, you're exposed to other toxins, you take that information to your physician, what can you do about it? And then you get the question between the participant and their clinician. How did you get that information? What are you going to do with it? So there's a big area of work that needs to be done in this area. So I'll stop there.
Yeah, thank you. I wonder, Holly, if you could comment on this. I know return of information is a big issue in All of Us. If you could maybe talk about how you have the conversation with participants in advance about what they want to get back and not get back.
Yeah, thank you. I would love to. So our participants are partners. They're involved in many parts of our governance across the program, especially around return of information. And we really engage them as actively as possible. So our participants have the ability to choose which results they want to get back. And so we have a responsible return of genomic results, and there are different types of genomic results, right, that you can give back to a participant. For each type of those type of results, medically actionable traits or ancestry are kind of the large three buckets that we work with. They are able to choose which kind of grouping they want to inform. So we have a series of informing loops within the consent process for return of information that the participants are able to engage in. Not only do we have that kind of active online support, we also have a genomic counseling resource that we've put a lot of resources into. And both we have actual people on the phones that are there able to support them regardless of their genetic result, as well as the virtual experience that they're able to have.
Thank
Tuba,
you.
would you add anything there? Oh, sorry.
I don't know if she has access at the moment. I want to jump over to Paresh or Luke, noting there's also a question about whether people whose data is included in a large de-identified data set have some rights or should receive some information back if there's meaningful findings that come out of analyses there, or if that simply belongs to the health system or someone else. I wonder if you could comment on that.
Sure, this is Paresh. That is a really challenging question. I think it's easier for us to conceptualize what happens at the one end of the extreme, where you have maybe the data from one individual that has a lot of scientific impact. I mean, Henrietta Lacks would be an example of that. And then the other end of the spectrum, you have, say, Scandinavian healthcare systems, where when you query the data set, you can literally query the entire population. Somewhere in between is where you have, maybe 5% of the population really contributing to knowledge that helps the other 95%. Is there a responsibility of, returning some value to the individuals who participated? I think it's an unanswered question, and where that cutoff, if you will, occurs is really, I don't know. That's really something that we need help from ethicists on. But I think it's something that we often don't even think about with de-identified data. We sort of assume, okay, it's de-identified, the patient's no longer involved, and really we have to think about there's some responsibility back to that patient.
Yeah, I think you can think about some of the population level data, whole populations like Iceland who've participated in large research studies, and what that obligation is. It's a little different when you're part of an electronic medical record in a particular system. I wonder if we could pivot a little bit and thinking about some of the earlier conversations today, if we could maybe have a discussion of when you move from research to clinical implementation. And I think sometimes about the example of pharmacogenetics, where we had what is essentially prospective retrospective, because genetics comes first, prediction of outcome in antidepressant and other treatment that rapidly turned into tests that were available for clinicians to use in everyday clinical care. My experience as a clinician, mostly seeing patients in consultation, was it sometimes led clinicians to turn off their existing knowledge and defer to the results of the test. So I work mostly with kids with autism. I'd see kids who are on a medicine that has no evidence whatsoever in autism, but had a green light on the pharmacogenetic test result. And I think it's one of the things we have to keep in mind, that just having a prediction doesn't mean that knowledge of the prediction will improve clinical care. And I wonder if folks could wrestle with that question a little bit.
You know, along that line, actually, it's continuing the same line of questioning. You have often talked about the fact that the most important stakeholder for technology are the end users, the people the consumers. And so the question that Jeremy is asking, how do you see it from the perspective of the end users?
You know, it's a great question, and I think there's a lot we don't know. I think the more the people we're trying to serve are engaged in the process. I love the earlier comment, you know, that when you're designing something, you're asking them in real time, what would be useful for you? Because life is full of surprises. And some people may or may not want to schedule their appointments on their phone. They may be too paranoid for that, but some people will want that. I think it's going to differ by person. Anticipation of relapse will be important for some people, but I think ways to stay connected to others for people that are isolated, pre-viral isolation, you know, due to their vulnerabilities, will be helpful for others. So I think this is a very interesting space. I think there is opportunity, and I salute those of you that are asking this question, because I think this is the linchpin of this making a difference in people's lives. So as you're asking the question, you're doing the thing that I'm really hopeful that you would be doing. So I applaud your thinking.
Thank you. Anybody else has comment on that?
I was just going to make a general remark that we do have some other ethical experts who are not speakers but are participating online. We also have some Q&A from the chat box and Q&A box, which David Lightman is queuing up for us. When you're ready, just call on David and he'll bring that forward.
One very brief comment I just wanted to say, and I think that this was highlighted very nicely in each one of the panels today, is that like we kind of fall into this binary either or situation, but I actually really do feel, and I think this was so well underscored each panel, that it has to always be this kind of shared agreement between the clinician and the patient in terms of what tools are appropriate, that is guided by kind of clinical insight and the patient's insight and relative experience. So I don't think that these tools will ever exist in a vacuum, particularly as you think about moving from high income to low income countries, you know, from youth to adult populations who embrace technology in very different ways. And so I guess I just wanted to maybe make that comment.
If I can just briefly comment on Jeremy's original question, is how do we get that information back to the clinician and get the clinicians to use it? And that is, as Jeremy probably are very familiar with this, but those of us in clinical psychiatry have there's very good data to establish that measurement-based care is better than standard or treatment as usual. And despite the strong evidence, it's very challenging to get clinicians to change that framework. Some data suggests it takes 17 years or something on that order to get people to change their practice. So it's really like literally training a whole new group of people with the new skill set, but we still got to keep doing it. I think it's really critical.
Absolutely.
And all of us, I was going to say, for when we're giving information, value, or results back to participants, especially for the medically actionable genomic results, we try to make the reports as useful and responsibly interpreted for the providers as well. The participant has to bring the report to their provider. We don't provide information to the provider. So we try to draw that line pretty starkly between research and medical care, but we try to make the information as accessible as possible for the participant to bring to their provider.
That's a useful principle. Holly, I wonder if we could go to some of the questions from the chat box or the Q&A.
Yes, so this is David Lightman speaking. So I've been looking at the chat box, and there's a question for Holly from Cara Ramos. Holly mentioned oversight of how all of us data are used. I'd be interested to hear more about that. And is there a particular framework they use for responsible data use? How do they weigh differing values, perspectives of researchers, participants, etc.?
We do have a lot of oversight, not only of our users in terms of the different credentialing that has to happen for them to gain access to our different tiers of data, but also to their behaviors in the research platform. So we are able to see their workspaces, and their peers are able to see their workspaces, and we publicly post the work that they do. So it's a nice kind of auditing, self-auditing, but we also have groups within the program that are responsible for that. We also have the ability for the users of the data to be able to volunteer review of their code and their workspace to see if it's potentially stigmatizing research, given our priority on underserved populations being represented in the data set.
Okay. Another question that arose from the Q&A is a question from Tim Mariano, who asks, how do we handle the risk of unintentional bias in digital tools? For example, a machine learning algorithm may not by itself be biased, but can provide biased output if trained on biased data.
I think that's just such a critical question. As as most people know, the data that are used to train the machine learning process are creating the algorithms that are being deployed. And if the data set is not representative of the people that stand to benefit from the algorithm, the AI that will be deployed, we're really doing an injustice. And so when I think about, the use of the electronic medical record and how it was designed for billing purposes. Now, for some cases like radiology, ophthalmology, there's some really useful tools and uses of AI that make it a complement to the physician's role. It is an assist. When it comes to mental health, there's so much more that we need to know before we deploy AI and do it successfully. And in fact, one of the studies that I'm involved in was planning to use artificial intelligence to look at medication adherence, which in effect creates a weapon that could inadvertently discriminate against people that don't use their medications. And instead of looking at the social determinants of why they don't use their medications, it could be working 2 jobs, having to get from one place to another, having, just so many things in life that influence our behaviors. It's critical that the data sets that are being used really reflect the people that we're building them for.
Does anybody else want to chime in on this question, or I can go to the next question?
I think this is Luke speaking. The bias question I think is really interesting, and also it's a really difficult thing to figure out what the right thing to do is. And I know it's certainly an active area in the machine learning community about how to deal with this, because on the one hand you want to be able to, we know from Paul Neal and about actuarial versus clinical, how we basically can make judgments and how many dimensions of features we can actually use. And humans, even clinicians who have lots of expertise, they're still not using that many dimensions, maybe not more than like 3 simultaneously, where we can have algorithms that can use many dimensions and also do really complicated things on how we extract features from that data. So on the one hand, if the goal is to predict something, then we might not want to really muck around and muddle with the features because we don't really understand how everything interacts. But on the other hand, we might want to downweight certain things because in our cost function, while we might want to predict, we also might want to be minimizing bias. And we don't really necessarily have a good way to put that in our cost function, how we're training the models themselves. And then further, I think another thing that makes it difficult is multiple people throughout the day have brought up interpretability. And so on the one hand, if we can see how a certain feature like a demographic characteristic or something like that is weighing in into the model, then you can basically choose to ignore that, or but when it gets really, if you're in these like deep learning things and you have all these nonlinear complicated interactions with millions of parameters, it becomes really difficult to figure out how to interpret it and how that bias is creeping into the model.
Thank you, Luke. I realize we are bumping into time, and we have the luxury of another hour for a broader discussion. Before handing things back to Dilip, I just want to say thank you to our panelists. Stimulating discussion. I especially appreciate folks acknowledging where there are questions that don't yet have answers.
Thank you on my behalf also. I think the speakers did a great job. Thank you all for keeping your comments in time. And so this 1 hour has been very productive. So back to Holly.
Great. Well, thank you, Dilip. Thank you, Jeremy, for leading the discussion on this very important topic. So the next hour is our general discussion. And over the course of the morning and early afternoon, we've heard from a broad range of researchers from a variety of disciplines, psychiatry, psychology, genetics, computer science, data science, engineering, just to name a few. We've heard from representatives from industry, including the electronic health record industry, technology and data companies, and pharma. We've heard from health systems like the VA. We've heard from SAMHSA. We've heard from professional organizations like American Psychiatric Association, nonprofit organizations, and patient advocacy. And you've helped us in a short period of time get a broad overview of the landscape about our future vision of delivering effective and personalized mental health care for all that works and is equally accessible to all. You've helped us examine and take a closer look at existing networks and approaches to appreciate their strengths and challenges. And you've helped us map out what are the issues in getting from where we are today to that envisioned future, with a very nice discussion about how technology may not be the major challenge. We also have to think about culture, incentives, ethics, and the human factors. To cue up our general discussion, I would like to go back to something that Ken Duckworth said, which I think is really worth underscoring. He told us that the NAMI call lines are being overwhelmed with people calling with mental health concerns in the midst of the COVID-19 pandemic. And that's our current reality. And he pointed out with that as a backdrop that patients are not well served by fragmentation in the mental health system. He reminded us that the patients that we serve are disappointed by prior treatments that overpromised and underdelivered. So with that in mind, I'd like to open this up to a general discussion, and I'd like to ask each of us to focus on what do we need to put in place concretely to be able to build towards a future where multimodal data can inform treatment selection for mental health in a way that's accessible and effective for all. And going back to the vision that Dr. Gordon presented to us in the morning, thinking about what role we can each play in achieving that future. The panelists are welcome to unmute themselves and participate. You're also welcome to use the chat boxes. And I've also asked our Q&A moderators from each of the sessions who had leftover questions to bring them forward so that we can have a fuller discussion. So I'd like to open it up there for discussion amongst the group.
Yeah, this Greg Simon. I've unmuted myself. I think you can hear me.
Yes.
I'll get on one of my soapboxes that some of you may have heard me climb on before. But to me, it's really essential that we distinguish between privacy issues and proprietary issues. And my experience is that those sometimes get blurred to serve the interests of, particular stakeholders who basically would like and tend to be more proprietary stakeholders. So, one of the questions that came up earlier in the discussion is who owns the data? And at least, in my network or in the world I operate in, we are very clear that health system members own the data. There's no question about that. That's a legal principle, but it's also to us a foundational ethical principle that health system members own the data. They are their data. We borrow those data temporarily to learn from them. We are guests in that house, and that we have to behave as guests and always respect people's rights and try to communicate with them clearly about how, when, and where their data will be used. So that's pretty foundational. But then on top of that, when we talk about sort of the proprietary interests in what is learned from those data, I feel pretty strongly that that's public domain work. And if our members of these large healthcare systems have said, yes, you may use the data that we contribute for research, and when we've talked to people about this, they are pretty clear that they feel a strong obligation to help other people who might also suffer from mental health conditions, but they have strong objections to that knowledge being privatized. So I think, we need a pretty clear distinction between there. And, I think in terms of, creating the incentives for, privacy protection and public domain learning, or, as I sometimes say, if your code and all your results aren't on GitHub, we should say it never happened. That's my soapbox. I'll climb down now.
Well, thank you for raising that. And the topic of balancing access and open source, not only with respect to the data, but also the algorithms that are built from the data, balancing that with the privacy issues. And you raise another aspect, proprietary nature. We do have representatives from different sectors here, industry as well as academia, and I'd love to hear some discussion, because I think depending on where you sit, it influences what you experience on that divide. In terms of accelerating science, we think that open source data and open source algorithms using things like GitHub, depositing your data in the National Data Archive, for example, these can be research accelerators, but there may be incentives that are disincentives, let's say, from people participating in that. Can we have any comments on this issue?
Yeah, well, this Greg, if I could just add one comment, because I think there clearly are privacy issues related to data sharing, which our group is way into the weeds on and happy to talk more about, but it gets very nerdy. But there are no privacy issues related to sharing of code. So for us, patients' data are behind a pretty high wall, and we have to be very careful. But every line of code we have ever written is on GitHub.
And may I ask the researchers here, do you agree with those comments, or is Greg the outlier here?
I'm happy to fully support Greg's sharing of code in GitHub, or at least the code. The data, I think, is really complicated, and I think on the one hand, I think I really appreciate his perspective that he, where the patients own the data or the network owns the data, and it's the privilege of everyone who has to work with it. But then on the other hand, there's a bunch of things when you start adding. This is more from my end user, not so much from my data generating hat. When there's really large barriers to accessing the data, it makes it so. For example, even the NIH's data sharing, it's great that they're putting all this effort into it. But then on the other hand, it's in practice, I find it really hard. It's very hard to put data in, and it's really hard to get data out of it. And other things, I've waited years sometimes to be able to get access to data sets and then been rejected, or you have to jump through so many hoops. You have to get a legal team in, and not everyone has resources to be able to do that. And so then it's not really democratizing, or whatever, how you pronounce the word, access to the data and the types of questions and things that can be used with it. So I feel mixed about it, but I fully appreciate Greg's point.
So I think you're making the point that it's not just about researchers being willing to share their data, it's about making it easier to access, lowering the barriers for investigators to be able to use that data. Other thoughts on this topic? Data sharing and code sharing.
Greg, I was going to add, I am a big fan of what all of us is doing in this space. And I wanted to sort of go back and underline something that was talked about related to all of us, which I think is going to be a really big issue for the research community to think of. It's that the specific sort of, all of us idea that you can have access to these data, but you need to operate in public. Meaning, Jupyter notebooks, I'm getting nerdy about that, but or whatever system you're using to access those data, your code are available for public inspection so that people can make sure you're not doing bad things. What that means is that some of researchers' proprietary interests, I'm able to ask questions privately and keep the answers private to myself until I'm ready to release them, have to go away. That would certainly accelerate learning and would break down silos, but it has not been part of our culture to say that everyone in the world can see the results of my analyses as soon as I can see them. That would be a radical change in how we do business.
And that's another aspect or element of trust. When you were talking about do people who provide the data trust the systems to keep it private, there's also another trust issue of science. Do we trust the researchers or the scientists to be transparent about how they're using data, how they're generating those results? These are fundamental issues that are key to reproducibility and rigor in science, and something that we definitely care a lot about at NIH. For us to trust And let me just remind, as you want to make comments, please unmute yourselves. And we do have Adam Thomas, who's monitoring the chat box and Q&A box if you want to make comments there.
Yeah, if I could this is Jeff Gerard here. If I could weigh in on Greg's point about the sharing of code, I think, as a general principle, I fully endorse that. But I do think that there's nuance here, of course, which he alluded to. I think there's different reasons to share code, different purposes for doing so. So there's probably a continuum between, perhaps sharing your code in order to just show, hey, these are the analyses I did. You can look and check for typos or bugs. And it's much more about that reproducibility, transparency piece. Hopefully, there's very little kind of argument against that. It's hard to imagine what the downside of that would be. I think but there's also on this continuum, there's also the purposes of sharing for, like, let's say, developing software for other people to use, right? So let's say we want to implement this model that's going to, like in the type of work that I do, will detect facial expressions. Now other people are going to download the software, use it on their data. And I think that that has the potential to be an incredible accelerant to work. But it also, I think, with that great power comes a great responsibility to make sure that if you're going to make something easy, that we're accelerating us on the right path. That we're not going to charge down on something that's poorly validated or not working, that is now going to sort of balloon into this whole area that's not very trustworthy. So I do think that, yeah, like the more you expect people to reuse your code, the more effort you need to put into validating it and commenting it and documenting it, things like that. So that's important, I think, note to add.
Yeah, thank you for sharing that. And I know that we have computer scientists and more professional software developers who are participating. I think it might be worth discussing what sort of collaborations are needed across disciplines, from the clinical sphere, clinical research, collaborating with the computer scientists or software developers, or the engineering side, to be able to be sure that those software tools are well documented, able to be used by others, don't break when the operating system change, and are supported. And it's a big deal to support software. I mean, typically companies support software, but there are open source examples of like Linux or things that are where the package is open source. Can I hear some discussion across these disciplines about what sort of collaborations are needed?
Holly, Oh, sorry, I'll just add really quickly that before we go on, because I think the collaboration piece is an excellent one. I think another thing is funding, that a lot of those open source software packages are really being supported with like people working nights and weekends, like blood, sweat, and tears putting into these things. And I just think there's not enough funding for that type of really critical work. But also the collaboration piece.
Was that Guillermo? Someone else wanted to speak?
Yes, thanks, Holly. I just wanted to make a quick comment about sharing software. There is multiple, as what you said, there is multiple reasons, but one of the ways to share software and data without sharing software or data is through cloud computing, something that we are exploring, and Duke and other universities are connecting their health system with the cloud, PHI, HIPAA, everything. So that will allow you at any institution to run my software without me having to share the software with you, and will also allow me to test on your data without you having to share the data explicitly with me. So I just wanted, from the technology perspective, that a lot of the concerns that we are having are going to be improved with the use of cloud computing. So security, transparency, who touched the data, who touched the code. So I'm basically, that's actually the meeting I'm jumping in the next 15 minutes. So I just wanted the non-technology people to be aware that there is technology not to address everything, but yes, to address some of this sharing, both of software and of data. And as I said, there is multiple institutions that are leading and paving the way for that. And I would be happy if somebody wants to know more to contact me offline. But it's not just the old-fashioned that I have to send you my code that you have to install. Many institutions and many companies are working very hard to make a standardization of software for healthcare through cloud computing.
Thank you, Guillermo. Those are very important points. And this may be an example where there are already existing technological solutions, and the problem is not the technology per se, but the incentives that make the individual's stakeholders unwilling to use those solutions because of wanting to keep things proprietary, either for research reasons or for reasons of their own industry and financial interests. So I'm wondering if we've been talking about data sharing, and I know we do still have our colleagues from EPIC on the line. When we think about the clinical data and regarding privacy of clinical data within our electronic health record system, and of course we have multiple electronic health record systems. And so it's a bit of a patchwork of different systems that are in use across the country and across the world. I'm wondering, I'd love if our EPIC colleagues still on the line might want to address how they view this in terms of the idea of how we might share between electronic health record systems or our colleagues from the MHRN or other large networks that have addressed interoperability between and across EHR systems.
Yeah, so I'll be the EPIC guy on the line. But yeah, I think there are some well-established standards for exchanging information between health systems. Those kind of fell out of the meaningful use initiatives. One barrier I see to doing that is that a lot of behavioral health providers were actually exempt from those meaningful use and EHR incentive programs. So in our experience, there still is a lot of faxing and phone calls and mailing to work with some of those organizations. So I feel like maybe from a national level, getting some incentives there might be useful. Another sort of thing that I'm thinking through that we need to be thoughtful of is interfaces are great, but I think we need to be thoughtful not to have 13 or 14 different standards that folks are programming to, because then all of a sudden your EHR vendors are going to be just programming interfaces all day. So I think one area that we use help from an industry perspective on is getting sponsorship of interface standards and holding different software vendors to those standards, which is kind of a tricky thing too, especially as this is a rapidly evolving field. But we will need interfaces so that we don't have to reinvent the wheel if organizations want to plug and play with data. So that's kind of my thoughts on that one.
So thank you for that. So you're pointing out that meaningful use was meant to facilitate the sharing of health data as people move through different health systems, but you commented that for behavioral health, there's exemption. And you commented that there might need to be some national incentives to overcome that and sponsorship of interface standards, holding software vendors to those standards. Can you say more about, for those of us who are not in the software and computer science space, about this, what you commented, sponsorship of interface standards with software vendors? What would that look like, and in whose domain is that?
I think it falls somewhere in the software space in terms of who defines standard. You can imagine two computer systems talking to each other. They need to be speaking the language to have a meaningful interaction. However, if you're expecting sort of one system to speak 100 different languages, that's hard to implement and support from a technical perspective. Whereas if everyone was speaking the same language, the data flows much more smoothly. So that's kind of what I'm referring to when we talk about interface standards. Part of that is a common sort of dictionary of data elements. For traditional medical information like medications or diagnoses, we have things like RxNorm and ICD-10 that kind of provide those standardized code sets. But for a lot of the sets of information that behavioral healthcare providers care about, things like questionnaires or other social factors, those data dictionaries don't necessarily exist yet. So I think one thing that we could get help from groups like NIMH would be to have those standard data dictionaries, because then everyone's programming to the same standard.
Great, thank you for that. And I'd love to hear from a lot of our investigators who spoke earlier, commented on the strategies they've taken to try to interface with the EHR and use it for improving mental health outcomes. And so I'd love to hear some discussion between these groups about where the potentials are.
Hi, this is Diana Clark from the APA.
Thank you. Go ahead.
I think one of the things that we have actually, and it's something we've actually sat down and talked to NIMH about as well, is this idea of actually, I agree, identifying common data elements that can be used across the different health systems and the different EHRs. And I mean, that is going to be extremely important for us to have comparable data across the different systems. And another way to do this too is, in addition to identifying common data elements, another thing that could be done and is to, even if different EHRs and different systems are using, say, for example, different patient-reported outcome measure for the same outcome, for example, depression, if you can figure ways to create a crosswalk between those, so that even if one system is, and limit those tools. And so even if one system is using, for example, the PHQ-9, and another system is using, for example, the GDS, because we know that for geriatric patients, the GDS tend to work better for them as opposed to the PHQ-9. So something like that, if we can figure out a way to make that crosswalk, that would be really, really important. And that's something that I know we at the APA, we're trying to work towards. And for example, working with a team from ARC team, AHRQ, to actually try to see how can we harmonize depression measures across different registries, for example, ours as well as the PRIME registry, and then across different health systems. And so it's something, we're taking steps towards that, but it definitely, I agree with the EPIC person that we have to have common data elements, define the common standards in order for us to have data that can be comparable.
Great, thank you. Those are very important comments. And so it's not just the software interface, but it's also the measures themselves and having crosswalks across the measures so that we can be able to look at the same thing, whether it's a measurement of an outcome or a clinical feature across systems, because and it was in the earlier nicely mapped out some of the challenges that researchers face when you're trying to do research in the real world. You're having to make use of what is actually there, and it may be a different type of thing that you would have measured in a more conventional clinical trial type of setting.
Holly,
yes.
if I can raise a point, and this might be a good point to intervene on that. There's as someone mentioned earlier, there's an engineering problem, but there's also a sort of a social cultural problem. And I think this is something that maybe Matt from EPIC, you can speak to if you have enough line of sight to it. But something like Cosmos, which is, an attempt, EPIC's attempt at a very large sort of common data model structure, there are challenges there for using it for research. And I don't know if Matt, if you have any line of sight, what are the social cultural challenges to using that data for research? Because clearly that data can be used for clinical purposes, but the rules of the road limit how it can be used. And maybe those will speak to some of the barriers to using that kind of data for research.
That might have been my phone. Sorry, everybody. Presh, I probably don't have all of the insight into the Cosmos data set and some of the challenges there. I do think there is an opportunity there for either usage of the Cosmos data set or a similar model. Kind of the idea of Cosmos is that we use the same interface standards that EHRs use to talk to each other to pool into a common medical data set that EPIC organizations have access to. And the benefit there is that we sort of have that common language and that common use of that data for organizations to use, and we can do some of this more advanced research without having to worry about sort of the data translation components of it. So that's something we're working on. I'm not sure, Paresh, if you had sort of more targeted questions for me on that one. I know I'm not the Cosmos expert here, but.
Sorry, I hope I'm not causing the feedback.
Sorry, I think that is coming off your line, Paresh. This is Adam. I'm hosting. I just hit mute all, everybody. Can you try again, Paresh?
Okay, now okay.
Seems to be okay.
No, Matt, I was just speaking to, early on, and I think this is, while I didn't want this discussion to be EPIC-centric, early on when we were looking at things like Cosmos, which are really large federated data sets, it was, the challenge is institutional resistance to sharing data for research. And I don't know how that's evolved over time, but it's one of those, it speaks to how hard it is to get that data together across multiple centers. And that maybe there are opportunities there for developing a common framework for sharing that data.
One thing I wanted to bring up is what is in the data set to begin with and what is actually in the EHR. When we think about mental health treatment, it's not just about medications, it's also about psychotherapy and behavioral interventions. And earlier in the day, I heard comment that we might know that a psychotherapy session occurred or was paid for, but we might not have in the EHR information about what type of therapy or the quality of the therapy yet. And I'm wondering if any of our colleagues on the line who may have a background in this have any comments about should we be capturing something more about psychotherapy and cognitive behavioral interventions?
Yeah, this Greg Simon, I was going to say, I think this is a really critical issue, and it's a real challenge. And I think we probably need to consider it at multiple levels. One of those is how can we at least get providers to record in a more consistent way specific sort of families or schools of therapy or therapeutic interventions, to at least report those in some standard way, and work with EHR vendors, especially specialty mental health EHR vendors, about trying to get people to record that more systematically. Eventually, it may be payers who say you really have to record those data, for payment, that may drive that. Another one that is very relevant this month is, in many of our healthcare systems, mental health care is switching to virtual care. And many mental health providers are now using various technology platforms to interact via video conference. And I suspect some of that will stick after we get past this crisis. There's an interesting question there, because what it means is that now the actual, the content, the lexical content, the tone of voice content, and even all the video content of psychotherapy is now passing through someone's pipe, when it used to occur completely in private. There is an interesting, fantastic, and also somewhat frightening possibility there of how we would mine those data. And I have colleagues who are very interested in those questions about how we might be able to mine the lexical content, the tone of voice content, and facial expression content from video psychotherapy sessions to learn about what actually happened. It could be a relatively dramatic advance in understanding how and why psychotherapy works, but there are a lot of issues to overcome about privacy. So that's but I think we have moved so far to virtual care in the last month that we will probably pull back from that somewhat, but I think it's going to be a much bigger part of our future.
Great, thanks for making that point. And it was referred to earlier in our session as the 3 V's of telemedicine, which I've not heard it referred to that way before, but the verbal, the vocal, and the visual. And as we are doing this conference right now, a virtual conference, we are communicating in those 3 ways. And the degree to which that sort of information can be used to improve mental health outcomes, certainly an exciting topic to explore, raising not only ethical and privacy issues, but also technical issues of how you handle that data and what it could mean. Any thoughts on that? I know we've got some real deep digital phenotyping experts who look at these devices and other types of approaches.
No.
All right, I had to mute all again. Please, there you go. Thank you.
Okay, this is Diana from the APA. So one thing that around the idea of online psychotherapy, I think we could probably learn from the Australians in with that, and just kind of reach out to see what are some of the results they've had, because since 2012, I do know that Gavin Andrews and his group in Australia have been doing online psychotherapy and with video conferencing, and so we could potentially learn from them as opposed to starting from scratch. Then so that's one thing, and then the next piece I was going to actually, oh my goodness, it slipped from my brain. I'll remember and I'll come back to it. It's gone. Sorry. I guess I need another cup of coffee. The second thing I was going to say is completely gone. But we can actually learn from some of our colleagues in other parts of the world.
Yes, so thank you for that point. In terms of the telemedicine, telepsychiatry, online psychotherapy going on. And I think the issue that was being raised was how to capture that data. How useful could it be, and how, if it's being captured, it might change the therapeutic interaction. Any other discussion on that?
Okay, sorry, I'm going to go back to the issue that I wanted to really talk about, but then I jumped in and mentioned that. I agree with Greg that we do need for a standardized way that clinician, for clinician to document things. But I really do believe, and this is something that we hear from clinicians all the time, is that we have to really make sure we balance the clinicians clicking off a box and selecting something versus having the ability to write their notes, free form notes. So we have to balance those 2 things. So I wanted to say that first, because that's really important. And I know that's where you do find clinician opting out of certain things because they find that they're just having to click all these boxes, and it's supposedly interfering with their ability to do the clinical work that they're supposed to do. So we need to balance those 2 things.
I'm really glad you pointed that out. We've talked some about patient burden, but what you're bringing up now is provider burden. And when we consider the pressures on providers these days, as many of you well know, If it doesn't help the provider be more efficient and take better care of the patient, it's probably not going to happen because of the time pressures. So delivering value to the clinician is clearly very important, and being able to do that in a way that does not add to the burden of documentation.
Ellie, this is Peter. I'll just speak to that a little bit because we were doing that with the, am I on mute? No, sorry. We're doing that with the ECT clinics in the NNDC, where we're trying to encourage harmonized documentation of the ECT procedure. And in doing that, we are trying to focus on two goals: it being clinically useful to the providers and to the patients and to the actual clinical encounter, and at the same time collecting structured and harmonized data from that ECT procedure that will be useful for these sort of research and quality improvement activities down the line. And I think that same sort of thinking can be applied to, say, psychotherapy or other types of procedures. And I think it is a worthwhile thing to think about. So it isn't what we think about when we're dealing with EMR data, where it's garbage in, garbage out, but we're getting good data that's not only good for clinical purposes, but also for research purposes. I will say it's a lot of work. I spent a lot of time with the clinicians trying to get them to think through what would be useful in documenting these procedures for them clinically, but also can be captured in a way that will be useful for research purposes. It's just a lot of.
Thank you for bringing that up, Peter. And when we think about how we can use these streams of data, including the EHR, to inform treatment selection, we're discussing now, do we have adequate information in the electronic health record to be able to make that, to inform that treatment decision? In the case of medications, it is common that you have the medication name and the dosage in milligrams. But in the case of procedures like ECT or TMS or psychotherapy, you might have an indication that the procedure was done, but you might not have the dosage or enough information about that procedure to be able to have the system learn how best and in whom to use it, because it's like writing down, I prescribed Prozac, but not bothering to mention what dosage you prescribed. And that, that's just not enough information to inform that. And so in thinking about what things we need to put in place to concretely to build towards a future where multimodal data can inform treatment selection for mental health, this is one of the concrete things you're illustrating, Peter, building into the EHR sufficient resolution and documentation of the procedures that we're actually doing. And your ECT example is one very good example of having done that. And may I ask you, did you build that into Epic? And is that something that can be shared? And do you see this being becoming a standard on how to document the ECT procedure?
That's the hope, actually. Yes, we're working with all our clinicians across the NNDC to come up with some recommendations about what would be optimal for clinical purposes and hopefully for research down the line about these procedures. And we hope to publish a paper to report on those findings, and also to create tools, particularly in Epic, whether it's a flow sheet or a smart form, that we can provide to other clinicians so that they can easily adopt these flow sheets as a tool to document the ECT in their clinic. So the hope is that we can advocate for this becoming a standard way of documenting these procedures and spreading it, and not just within the NNDC, but beyond as well, to move towards a more standardized approach of capturing the structured information. And while we're doing this, I'll just go back to the point that Diana made, that I do think it is important to balance without doing this in such a way that doesn't burden the provider, and the provider still wants to document in their notes a lot of information. So we're trying to balance getting good structured information with the flexibility to add details in their notes. And again, yes, we're trying to disseminate this in a way that would become more standard with for other clinics to use as well.
Thank you. So when we're thinking about what concretely needs to be put in place to accomplish this goal, we've talked about a number of different factors, one being the literal software standards for interface across EHR systems. We've talked about the need for data dictionaries and common data elements, the need to balance the provider burden so that the thing will actually be collected and for it to be feasible. We've talked about open source sharing of the data and the algorithms and removing barriers to accessing the data and the algorithms. And right now we're talking about building up the dosage information so that we have enough information regarding the interventions that are given, so that we know, so that we can link dose to response. What else do we need to put in place? What needs to be built concretely to put in the framework where an AI ecosystem could be envisioned in the next 5, 10, 20 years that would become part of a learning health system for mental health specifically?
This is Peter again, just two comments to build off of what was already brought up by previous folks. One was I'd endorse the idea by Diana, work to establish how to do a crosswalk between different patient-reported outcome measures is a really interesting idea, because we do find different centers like to use different measures. And it would be good to allow them to continue to do what they like, but allow us to bring that data together and use it in a larger data set, even though they do have different measures. So I think that's something that could be encouraged, work that tries to evaluate and establish psychometric crosswalk between these different measures. And then a second point that I think would be useful in terms of concrete steps, and I'm not quite sure how it works. This builds on the point that Matt said. A lot of these patient-reported outcome measures, as he mentioned, they're captured in Epic, but there's not a standard coding system for them. And so they live in these flow sheets or smart forms, and each institution captures them in a different way. And so even within systems that use Epic, trying to bring that data together on the PHQ-9 measures might be a little bit challenging, not impossible, but it's a lot of legwork. But it would be made a lot easier if there was some standard nomenclature for pulling that data. I actually don't know what would be the way to drive that to happen. How do we incentivize adoption of coding systems for these other sorts of things that we don't have codes for, like low ink, for example? And I'd be curious if there is a way to encourage that or incentivize that.
Yeah, this Greg, I just wanted to comment on that point about standard nomenclatures for patient-reported outcomes. It is an issue, and there is nothing equivalent to LOINC. In our network, we have sort of adopted a standard nomenclature for representing PRO data that I think is relatively robust, because it allows you to capture, actual wording of questionnaires, mode of administration, things like that. It's a public domain, it's a public domain data model. We put it out there for anyone to use. We have also built a sort of crawler tool that will troll through the back end of anyone's Epic database, since our systems use Epic, and find all the instances of common mental health patient-reported outcomes by searching texts of labels, questionnaire items, and so on. All of that stuff, is free to share. I mean, we are not a standard-setting organization, so it's not like we would say other people should use that, but we'd say we've got some stuff that we think works pretty well for us, and you can have it for free. Just contact me.
That's great, Greg. Actually, I didn't know about that, and I will be contacting you about that.
So I'd like to do a quick time check. We have about 15 minutes left, and I'm really thrilled to see that we still have almost 100 participants on the line. You really stuck with us, and I believe that's a testament to the level of interest that there is in the community about these issues. I want to be sure that we cast a wide net here. I know that, Adam, you've been taking the questions from the chat boxes. I want to let you bring forward any questions that haven't been aired yet, and also other participants that we haven't heard from yet. I want to be sure that if you've been waiting for a break in the conversation to be able to make your points, that you feel welcome to do so now.
Thanks, Holly. There hasn't been a lot of chat questions recently, but I would like to take the opportunity to pull one in from early this morning that came in from Javier Gonzalez Castillo. And I might add my own spin. So he noted that there was some discussion of wearable technologies, and he was wondering about priorities. If people could elaborate on what they see as the most important and high priority data are to collect. But I would like to expand that a little bit. To suggest, like, what other priorities could we add? So that would include genomics, that would include other biomarkers. What do the folks on the clinical front lines think that the larger categories of data are that we're missing that could really increase our prediction quality?
Please unmute yourself if you'd like to respond.
This is Peter again. Sorry, I'll just jump in with a real quick comment here, just real quickly, that not so much a specific category of data, but what's interesting, there are a lot of these digital sensor type data that we've been talking about, digital phenotype dating, whether it's mobile or wearable technology. What I think, but others can correct me if I'm wrong, where there's a dearth of is connecting that digital phenotype data with the electronic medical record data to bring these two strands together to see how they correlate with one another and inform each other. And so I do think that should be an area of active investigation, how to bring those two data sources together to get at that multimodal goal that we've all been talking about. I do think we're lacking there.
I've noticed there's been, with the exception of maybe one or two speakers, been relatively little discussion of genomics. And given that the model that Dr. Gordon has suggested was to follow oncology, I'm wondering if people think that should be a priority.
This is Greg. Can't help but make a snarky comment, which is we have to have some phenotypes that are all useful before we can go looking for genotypes. And I worry that in our mental health space, we're still more like looking for a gene for shirt color than for eye color.
It's Roy here. So first, I can't help but point out that the first depression genes actually came from using really crappy big data phenotypes, in part from health records and in part from 23andMe. So as much as we decry our psychiatric phenotypes, they did lead us to find the first genes. I also can't resist pointing out that FDA lists more than 100 drugs on its own website, including probably 30 plus psychotropics, where genes are in the label. I think I completely agree with Greg that most of the, I like to wave my hand and talk about polygene words too, but Greg, right, we have precious little to go on with genomics. With the very unsexy P450 stuff that we've had for years. So as a field, we have P450, we know it affects drug levels, we know at the extremes drug levels affect response. So I actually think, in general, it's a combination of no one wants to talk P450 because it's old news, and no one wants to acknowledge that polygenic diseases or phenotypes just haven't really worked very well in treatment response so far. So I'm agreeing with Greg, but also pointing out the one counterexample is one that no one really wants to do anything with because it's not sexy.
Great, that's useful.
Sorry, can I also, this is Dylan Nielsen. I just jump in and comment that if the focus is purely on treatment response, to some extent, the phenotypes get much, much clearer. If you're only concerned with whether or not the patient subjectively feels better after they've taken a medication or had a treatment, it's a clearer question in some ways than what particular diagnosis they may or may not have.
Yes, Dylan, I want to thank you for making that comment and also encourage our other NIMH and NIH colleagues who are on the line to feel free to participate in this discussion, because we've really brought together a lot of experts from different areas within NIH as well. And so your comment about, it brings us to the focus of our discussion here, which is how we can use data to inform treatment selection. And that focus is very specific. Now, if getting a better diagnosis informs treatment selection, and that's part of it, but our main focus, where the rubber hits the road for what we wanted to understand better, is helping clinicians to select the right treatment for the right patient at the right time, and really realize this vision of personalized medicine for psychiatry and for mental health. And so, as Dylan points out, if you have measurement showing before and after the person improved, that is a pretty clear phenotype. Although I will say that you have to decide what measure to use and reliably measure it and make that available. But any comments on this focus on treatment as opposed to diagnosis?
So Holly, one quick counterpoint to the treatment outcome is easier to define. In some sense it is, in some sense it's not so easy. You were just alluding to it. Over what time frame? Somebody could have a sort of a quick response, but are you looking over 1 year or 2 years? Some people have partial responses. And so it's not so easy actually in these pharmacogenetic studies and these treatment prediction studies to find the outcome in a clear and clean way. There are challenges to it. I do think it's easier than maybe diagnosis, but it still comes with challenges about how to define a good outcome.
Thank you for raising that. And I know we have developmental experts on this meeting. And when we think about defining outcomes, it is, well, when and what stage of life, because there may be interventions done early that have different impacts later on in development. And so I want to remind ourselves not just to be thinking about treating diagnoses or clinical conditions once they occur, but should we be thinking about interventions in a pre-symptomatic period that might be preventative? Any thoughts about that?
This is Neil. Obviously, you raise a issue dear to my heart, except usually the interval you're talking about is beyond the 5-year interval for a study. So they're a little bit hard to plan or to get funded, I think.
Well, just to remind us, in Dr. Gordon's introductory remarks, he did paint a wide vista in terms of what time frame one might envision doing projects like this. And the time frame, as I recall, he painted could be beyond 5 years, could be 10 or 20 years, could be a longer. We want to hear from you. What would it take? Where should we be focusing? What are your thoughts about what would be the most impactful way to use data to inform care for mental health and to transform mental health care? I'm encouraging you to think really broadly. Don't necessarily put yourself in a 5-year box. Free yourself up to think broadly.
That was the best being corrected I've ever experienced in the past a long time. So this is good.
So, Holly, maybe while people think about that, can I ask a question?
Go ahead.
Sure. So I think I heard FDA for maybe the first time a few minutes ago in a little bit of a different way, and I apologize if someone else has talked about it during this this workshop. But what do people think the long-term strategy is, and what regulation and oversight they think that the FDA should or should not be performing in terms of these clinical decision support systems?
Yeah, I don't think that we actually have addressed that question yet. And so since we have a multidisciplinary audience here, that's David McMullen on the line, can you tell us more about what you mean by clinical decision support software and the role that the FDA devices branch has with respect to regulating that type of software?
Sure. So right now, this is something that the FDA is currently figuring out, but they do have draft guidance out on what they term clinical decision support software as a medical device. Might be another term people hear. But basically, if you have a product, because they regulate medical claims, where you are stating that you can help diagnose, treat, provide recommendations, then they are saying that they might have the regulatory oversight authority to regulate those. So you have to come in, demonstrate safety and efficacy, and they're sort of an objective third-party body for that. And so I've heard different systems being developed, and I haven't heard people talking about selling any of them so far. But for the long-term rollout of this and for clinical translation, there will likely be an end product. And so do people think about how to interact with the FDA or how to design the studies that they can be evaluated by them?
So it's Roy here. I think this is actually a place that NIMH can be extremely helpful as sort of an honest broker. Most investigators, most non-industry investigators don't have the resources or the to engage with FDA. The pharmas have, offices full of people to jump through the regulatory hurdles. But I think FDA has been clear with the software as medical device guidance about what they want to do. So I think if NIMH, if MH wants to see more of these kinds of things that R01 funded investigators develop, make it to FDA. I think some support, some sort of mechanism to help investigators engage with FDA would be really helpful, because most of us are happy to get our models out into the world. I don't have the time to hire FDA lawyers, and frankly, I'd rather put my software out in the world and let someone else worry about commercializing it, which is what's happened so far. So this is a place where NIH really could.
Great, thank you. So that's a concrete thing that could be put in place to help realize this vision. Just to underscore it, you're saying mechanisms to help investigators engage with the FDA around issues like software as a medical device and what that regulatory path would be, as well as facilitating partnerships with other industries that would then take and support that software, which would not be supported solely in an academic lab. So bridging with regulatory, bridging with companies, and facilitation of that bridging. Did I grok your point right?
Yes, exactly. And given that there's already been toes dipped in the water with other devices, I think software as a medical device is a good place to go next.
Yeah, Greg, I was going to add, I'm fond of analogies, and one analogy I would like to use to talk about sort of the different stakeholders or players in this space is the weather world, because I'm a big weather nerd. And interestingly, in the weather world, all weather data in the world are pretty much in the public domain. We could go find them right now if we wanted, if we knew what to do with them. Then there's a middle layer of modelers and analysts who develop weather models, which is an interesting mixed space. It includes, nonprofits, academics. It does include some for-profit people, but that layer lives on top of weather data, and anyone can access all weather data, and a lot of people's models are out there in public for anyone to see. And then there are meteorologists who communicate, who work on television or on the radio or something like that. They are not modelers. They are not data nerds by and large. They're communication experts. At least, the way I see it in terms of the way, my group and my team operates is the data layer is the health systems. We are then that weather modeler layer. We're trying to do things and put them in the public domain. There need to be some meteorologists in this space who are about implementation, communication, and that is maybe a different skill set and a different business model, and those may be the people who bring these things to the FDA, and I am all for them. To me, it's an important sort of strategic question to think about which parts of this work lie more in that for-profit world, which it works, but I do need to acknowledge, maybe I'm in the same boat as Roy to say, I'm going to live more in the atmospheric sciences world than the meteorology sort of public communication world. And I would hope that some of those TV meteorologists would take the models that I build and put them to good use to inform the public about whether to have their picnic or not.
Great. Well, that's really a nice metaphor. I want to do a time check. We're about at the end. We have about 2 minutes left. And I'd like to again ask if there's someone else that has not had a chance to make a comment and you've been holding back, this would be your invitation to do so. And as you think about what that comment might be, I want to go ahead and thank our moderators. I want to thank all of our panelists. You've really covered a lot of ground in a short period of time. Really, really helpful to us. I want to thank our listening audience from the public who have signed on to join us, and to let you know that this is the beginning. We will be archiving this, we will be transcribing this, and we'll be learning from the information that you brought forward to help inform what needs to be put in place to be able to build towards a future where multimodal data can inform treatment selection and transform mental health care. I want to go back to the words of Ken Duckworth, who had to step out. Obviously, a lot of pressures underway in terms of the mental health needs of the patients that we serve now more than ever. And we want to really provide not a fragmented, but an integrated, a cohesive system of care that can help patients thrive and get the care they need wherever and when they need it. So let me just open it up. Any last comments from my fellow program committee members or anyone else? And hearing none, I want to thank you again, and we appreciate your input, and we're going to digest and think hard on what you've taught us today. I know I've learned a lot, and thank you for your hanging on with us to the end, and I'm going to go ahead and adjourn. Thank you so much. Be safe, stay well, and take care. Thank you.